in which failure to oxygenate may lead to hypoxia and cardiac arrest following hypoxic brain injury and death. Now coming to the most important part of the guidelines, emergency cricothyrotomy. We should all be vigilant and we should all learn these procedures because this is a life-saving procedure. Laryngeal handshake should be done. For an emergency cricothyrotomy, include surgical cricothyrotomy, needle cricothyrotomy, and wide bore cannula cricothyrotomy. Surgical cricothyrotomy technique requires a scalpel and a stab knife, a bougie, and a fixed size 6 tracheal tube. During surgical cricothyrotomy, the apneic ventilation is to be maintained. This is a photo showing a cricothyrotomy. A horizontal stab is made. First of all, a laryngeal handshake is done. Cricothyroid membrane is identified. Preferably, during a PSC, a cricothyrotomy, it is better to mark a cricothyroid membrane during a PSC before induction, because during a case of high adrenaline rush and the airway is failing, it may be difficult to locate the cricothyroid membrane in an obese patient. It is better to mark beforehand. Preferably, you know exactly the position. Give a horizontal incision. Twist the scalpel blade 90 degrees with a sharp end facing caudally. Insert the bougie by the side of the knife. Remove the knife and railroad the tracheal tube size 6 for 3 centimeters over the bougie inside the airway. Remove the bougie and furthermore maintain the ventilation, maintain oxygenation, and this procedure of a cricothyrotomy to be changed for a surgical tracheostomy later on to prevent any stenosis. Needle cricothyrotomy is done with a cannula of 12 to 14 G. Generally, this is familiar with this technique because in a Sellinger's technique, we are more familiar with this. Wide bore cannula method is also present. This is the guidelines. Maintain summary of recommendations. Does video laryngoscopy improve success rate of intubation? It does improve and is recommended as a primary device in rescue situations. Does the use of a bougie or a stellate improve intubation success? It is a best practice statement. A bougie always improves intubation success and a stellate can be beneficial during an intubation. Does apneic oxygenation during intubation reduce the risk of desaturation? Definitely, but it also increases the CO2 absorption of the patient. Now, consider interchanging between the 3 devices. IDA guidelines 2025 specifically is a bidirectional method. You can use any method that suits. None of the methods have been given as an algorithm. Should neuromuscular blockade be administered when difficulty with mask ventilation is encountered? Neuromuscular blockade should be administered to improve mask ventilation. At what oxygen saturation should laryngoscopy be re-attempted? A brilliant question. It is average as a guideline 95% of SpO2. What is the maximum number of attempts at tracheal intubation? 3 attempts of intubation should be tried to limit airway management related complications. What is the maximum number of supraglottic airway insertions to be tried? 3 is the magic number. Which cricothyrotomy technique should be performed? A surgical cricothyrotomy should be performed when there is complete ventilation failure. Limitation of device attempts. Generally also, other people should also be brought in the loop who can count the number of attempts, because it is often anesthesiologists may fail to note the number of times they are attempting the airway, which may lead to airway edema. Other people should keep a count. Sir, this has been the 3rd attempt, kindly change. This is a better method to involve other people also inside the team building method. Post-procedure plan. Once oxygenation has been established, airway edema is suspected, preferably it will happen, nebulized with adrenaline, and it will help in airway securing later on. Converted to a tracheostomy at the earliest to minimize risk of stenosis. And last but not the least, document the entire event and counsel the patient and family or the relatives that this has happened. We have been able to secure the airway. This was the injury. This is the problem, and these are the mediations. Because accepting a tracheostomy for a routine procedure sometimes becomes difficult for the patient relatives, even for a patient. Thank you.
I want to ask only one question. You mentioned Sugamadex for Rocuronium. Suppose the surgery has to be done because of emergency purpose, then you couldn't intubate and you extubated the patient. Then after how much time we should try?
It depends solely on the clinical situation of the patient. If the airway is swollen up, I do not think you should try on the same day.
No. What after how long we should try with for suppose we are going to go for GA only. We have already given Rocuronium, Sugamadex.
I think the best method should be used for this will be awake fiber optic. In an airway in which you are facing a difficulty in a normal intubation scenario, preferably if video laryngoscopy also fails, awake fiber optic with a proper explanation to the patient and relatives with a proper consent, because you have to give 3 or 4 injections to the patient, he or she has to accept that. You will be doing the airway under vision. That is preferably the best method, and also prevention of litigation further on.
So muscle relaxant what?
Muscle relaxant, scoline is probably going out of fashion. Now, steroid muscle relaxants like veteronium or rocuronium. Rocuronium is preferably the best choice right now because there is an antidote available in the form of Sugamadex. You just increase the dose, patient may come back. But that is preferably the drug of choice. If you have a difficult airway, that is the main crux of the story is you should be prepared. Counseling the patient beforehand, see, some and 10% and unanticipated cases will happen. You are not prepared for that. But at least some preparation, some mental preparation, some documentation should be done prior when you are attempting such a case.
Just I am asking for a new anesthesiologist who just joined a center where there is nearby, like for around 1 hour, he won't get any assistance. Then in those situations, what to do?
Find other methods. If the airway is swollen, I do not think it is prudent to re-attempt an intubation after 6 or 7 attempts has been done. Preferably you can't see. So either take mitigatory steps, measures, because probably in a rudimentary setup, video laryngoscopy will also be probably not available. So,
thank you, Doctor, for your insightful deliberation. If there are no questions, if anybody wants to ask any question, and if there are no questions, I think we should move ahead with the next topic. Thank you, Doctor.
Thank you, sir. For our next seminar, I'd like to invite Mr. Ayaz Ali on the stage to present about the PNB safety guidelines. Mr. Ayaz Ali is a product and marketing specialist. He is affiliated to Pharmacy of Excellence, Pharmacy Council of India in Pharmaceutical Management. He led Turon Medical Device participation at RAISACON National 2024 and 25 as product specialist. We welcome you on stage, sir.
Yes, so good afternoon, doctors. My name is Muhammad Ayaz Ali, Product and Marketing Manager from Torn Medical Device. And today we will be discussing on triple monitoring. Okay, like how advancement in the new medical devices is helping out your practice. Okay, and those such we are having a PNB guard, that is our monitoring device. It's an injection pressure manometer which helps you to achieve the precise nerve block and eliminates the chances of nerve injury. So before I start, I just want to give a quick introduction of the company. So I started back in 1993 and now working in more than 18 countries. We are having more than 220 plus product portfolios, okay, with 1880 specifications. We are having totally 6 manufacturing facilities with 8 subsidiaries along worldwide, among which in India, we are having our headquarters in Gurgaon. We are even having a museum of medical sciences, which is spread around in 1600 square meters area. Okay. So coming back to the topic. Okay. So first of all, we'll be having a quick introduction. As we all know, the peripheral nerve block, that means whenever we want to go for a surgery, we inject a local anesthesia near around the nerve. Okay. So that the anesthesia, analgesia or chronic pain management can be done. So during the time of PNB procedures, there are basically 3 major clinical problems. The first is the needle fascia contact. That means our needle has got in contact with the fascia. And when we inject drug in such case, it is a complete failure of the anesthesia. All right. The second problem that we get is a intrafascicular injection. That means our needle tip is got inside the nerve. Now since area is small, resistance is more, and when we are trying to inject the drug, okay, in this situation, it damages the nerve and create a very longer duration paresthesia or maybe a paralysis effect. The third issue is the needle nerve contact, in which our needle tip has got into the contact of the our nerve, and in this situation, when we try to inject the drug, because of the resistance, we cannot freely inject the drug, and then we try to provide some force, and because of that force, again, neurological structures get damaged, and which creates the damage to the nerve. So to eliminate this type of problems, basically we go for a single or a double monitoring and now triple monitoring also. So earlier in single monitoring, we used to use ultrasound or maybe a nerve stimulation machine, which helps us to know like exactly where our needle tip is situated. All right. So earlier we were having the ultrasound or the nerve stimulation machine. So basically when we were using any one of those machines, that is a single monitoring. When we use the both, that is a double monitoring. But yes, what's the main problem is, even after knowing where our needle tip is located, we are actually not knowing at what pressure we are injecting the drug. Okay, because as per the international NISORA guideline, the injection pressure should be less than 15 pounds square inch. If we are injecting more than at a pressure of 15 psi, in that case, nerve damage or nerve injury can happen. Okay, so here now with PNB guard, that our company has come up with a PNB guard, you can perform a triple monitoring. That means using injection pressure manometer along with the ultrasound and the nerve stimulation, so that you very precisely you can inject the drug and nerve damage can be prevented. So this is the guideline. Here is a small introduction for the product also, that injection pressure manometer is having a numerical marking with the color belt indicator. So here now you can see from 0 to 15, it is in white color. That is a safe pressure. All right, because as per the guideline, it should be less than 15 psi. So basically below 15, we are having a white indicator with a numerical marking. Okay, so precisely you can inject the drug. More than 15, that means 15 to 20, we are having a yellow light pressure. That is a cautionary pressure. That means during the time of injection, if your indicator got into the yellow zone, then that means you have to immediately stop the procedure, and you can reposition your needle, or maybe you can manage your pressure, at what pressure you are injecting the drug. All right. The third is more than 20 psi, that means 20 to 30 psi. It's a red light pressure, which indicate if your indicator is into the red zone, that means you have already damaged the nerve. All right. So this is the basic of this product. So yes. So earlier we have launched only with the injection pressure manometer, but now we are trying to provide a complete nerve block solution to our doctors, okay, who is practicing here in India. So first time in like globally, first time we have launched this product here in India itself. It's a PNB Guard Plus that is having a injection pressure manometer along with the PNB needle. Okay, so now what are the advantages? So first of all, the manometer is having a high accuracy of plus minus 1 psi. Second, it provides you high pressure alert. That means with a numerical marking and the color belt indicator, you can safely see, even sometimes it happens that it my observation that doctors are busy with the ultrasound probe and the needle. Okay, many of your subordinate clinical staff, they are injecting the drug. Okay, so at that time also maybe you are the experienced one. Okay, but you are not knowing at what pressure, at what resistance they are injecting the drug. All right, so here by this type of product, you can even monitor their practice, like at what pressure they are exactly injecting the drug near around the nerve. Okay, so then precise pressure marking we are having, it enhances the patient safety. The second, we are having here two type of kits we have launched. The first one is our PNB Guard CS. That means it's having a catheter and stimulating needle. So what's the main benefit of this PNB needle is that it can be used as a single shot plus continuous anesthesia. It is having a con technology. That means catheter over the needle technology we are having here. So here you don't need to thread the catheter individually. Here you will be inserting the needle along with the catheter. If you want to go for a continuous block, just leave the catheter there and take out the needle. It works similarly as the IV cannula. Okay, so for the continuous one, in continuous one, we are having the manometer, the needle, the drug filter to prevent the chances of blockage of catheter, the catheter fixator, hypodermic syringe, as well as the needle. And the second one, we are having for a single shot. That means it is having a manometer along with the echogenic stimulating needle. Okay, and 20 ml hypodermic syringe with hypodermic needle. So here with these kits, we are trying to just solve your problem. We want to give you a complete nerve block solution. Okay, so with a single kit only, you can perform your complete procedure. So here are a few video for the product, which has been used in a live procedure. So yes, here you can see in the second video is being played. It's a safe injection pressure approach.
Entire injection on 6 to 10 millimeters of pressure. Done.
And here, doctor
We
is,
are beyond the alert line of 12 psi, but we are lesser than yellow line, so we are in the exactly safe zone. If yellow line gets up, so now we are more inside. See, we are mostly intravesicular. So what we are supposed to do here, we have to withdraw a needle slightly. Withdraw. Withdraw more. Yes. थोड़ा अंदर जाओ. Yes.
There's one more.
We just have to concentrate on the spread of flow clarity unfortunately. You can see the lateral plot, the posterior plot, and the medial plot all three very clearly. So,
So now coming to how to use this product, it's a very simple small device, okay, which can be used very simply. Just in a syringe loaded with drug, we need to connect the manometer. Then after that, we need to prime the manometer, and then we need to place one finger to check whether the manometer is working fine or not. If it is having any type of leakage, just dispose the manometer and use the new one. After checking the manometer, just connect it with the PNB needle or any needle that you are using for the plexus block. after connecting it, just under the ultrasound guidance or maybe stimulator if you are using. So under the double or triple monitoring, you just insert the needle inside, inject the drug under safe pressure, that is under 15 psi. Okay, if you are getting a high pressure, that means either your needle tip is not into the right position, or maybe you are going very fast, very rapidly you are injecting the drug. So just maybe maintain your pressure or reposition your needle. After that, after injecting the drug, just take out the needle and note down your opening injection pressure. Okay, so this is how we will be using the product. So thank you, that was all from my side. If you are having any question, you can let me know. Okay, thank you.
So मैनोमीटर है उसको सिंगल यूज है कि मतलब रीयूज कर सकते हैं हम?
Sir, it's a single use from our side. So that's why we have now made it into a kit. Okay. So that individual kit you can use with every patient. All right. So it's a single use disposable from our side.
आप लोगों के साइड से डिस्पोजेबल है, लेकिन हम लोग अगर चाहते हैं कि उसको रिपीट मतलब रीयूज करें तो?
So see, for 2-3 times you can reuse it, okay, because it is having a metallic spring inside, a calibrated metallic spring, okay. So every time you will do the ETO, the spring will lose some of its tensile property, okay. So maybe 2-3 times it can work, but after that the pressure range will rise, but maybe it won't be accurate.
Can you use on the same day or next day?
Next day, sir, no issue.
You can use on the next day also after ETO.
Yes, sir. Okay. Okay. Thank you. Thank you.
Thank you for your talk. Now, with the due permission of our respected chairpersons, I would like to call upon stage our next speaker, Dr. Anupam Mohanto, sir. Sir is a senior consultant in the Department of Medical Oncology at Health City Hospital, Guwahati. Sir is one of the most eminent and efficient oncologists, having a vast experience in diagnosis and management of a variety of cancers. I call upon Sir on the stage to please provide us an insight of head and neck cancer overview.
So good afternoon to all, and it's nice to be a part of 31st RAISACON as a part of guest faculty, and I offer my sincere thanks to the organizers and MSD. So MSD is the manufacturer or research company of key to the pembrolizumab. This is the immunotherapy molecule, which is have very broad range of indications in our managing cancers. So today we'll have a disease awareness in the head and neck cancer. So that will be the brief table of contents. So disease burden of head and neck cancer, it is one of the very most important cancer in India particularly, which has a very high prevalence as compared to the Western countries. So the burden, according to Globocon 2022, in India, head and neck cancer constitute almost 1/3 of all cancers compared to only 4 and 5% in the world. And among the cancer sites, oral cavity and lip is the most common site, and which is responsible for the most of the death. As compared to worldwide, around 389,000 cases new, and India 1,43,000. As far as mortality is concerned, almost 1,88,000 mortality, and India contributes to nearly 80,000 of those mortalities. And the lip and oral cavity, it is the second most number of new cases in the Indian population in 2022. These are the Globocon data. And India has the highest oral cavity cancer patients in the world in 2018, and it affects 1/4 of the male population and 1/10 of the female population. And the tobacco use has been identified as a risk factor in 80 to 90% of patients with oral cancer. And the pan tobacco, chewing, and poor oil has been accounted for oral cancer. And 95% of the patients with oral cancer contribute to the selected habit of tobacco smoking, alcohol drinking, smoking and drinking, pan chewing and smoking, and poor oil hygiene, etc. And survival rate, a retrospective single-institution cohort in North India with 218 oral squamous cell cancer patients, overall survival with head and neck cancer at 3 years was 67% only. And the survival rate of patients of early stage was better. You can see in the graph, overall survival in the early stage 1 and 2, it is 86%, and for the stage 3-4, it decreases to 78.8%, and at 3 years, less than half of the patients survive. In the distribution, among the all head and neck cancer sites in both male and female, and most common site is your larynx, 28% for the male, 13% for the female, and in second is the tonsil, which is 13% in male and 10% in females. And the clinical extent, it is 2/3 of the patients with cancer were diagnosed at the leukorenal stage for the head and neck cancer from hospital-based cancer diseases. And similarly, low proportion of patients with head and neck cancer presented in early stage. In the relative localized, almost 1/5, and more than 2/3 is leukorenally presented, and around less than 5% present with distant metastasis. So most of the patients present with locally advanced disease. In the classification, it is broadly according to the site anatomic, oral cavity, pharynx, nasal cavity, and larynx. Oral cavity, almost 35% overall cases. And in the pharynx, globally, among head and neck cancer, prevalence is 15.8%. And global prevalence of, according to Globocon, the nasal cavity and perianal sizes disease burden were not covered. And the histological, according to pathologic, malignant tumors may be squamous cell, adeno, lymphoma, blastoma, etc. And there are certain pre-malignant conditions also, which are leukoplakia, erythroplakia, dysplasia, and laryngitis. And the staging of the head and neck cancer, it is the fundamental goal of screening program is the screening of individual at risk of disease for which early detection is possible. Because most of the cases, almost 50% are oral cavity, so these are easily examinable. So, and we all know that head and neck cancer has a significant morbidity and mortality, and there is a survival advantage with early detection. And this ability to diagnose early stage tumor with a clinical based examination, and there is a higher incidence of patients with certain risk factors such as tobacco and alcohol abuse. And we have different guidelines, but we mostly follow American Cancer Society guideline, which advocates an oral examination every 3 years for patients over the age of 20 years and annually for those over the age of 40 as a part of cancer-related checkup. Among the screening, visual screening is the most important one. It is the most common, accessible, and opportunistic screening modality. It is simple, acceptable, and accurate screening test for oral neoplasia, easily accessible site for screening by doctor, nurses, and health workers for self-examination. And it can detect early neoplasia if provided as a part of routine medical care by health workers. And sensitivity to detect lesions varied from 57 to 61% in previous studies, and specificity is very high, 98.6% to 98.8% from a cluster randomized RCT in India. And early oral cancer have a better prognosis than those with advanced disease. And what are the screening strategies in India? The primary screening strategy, oral visual examination by well-trained auxiliary health workers with tobacco and alcohol reduction counseling. And the target age group, those are high-risk population individuals who use tobacco products, alcohol, betel nut, or pan masala. Focus on adults in between 30 and 60 years. And the screening frequency, target once in every 3 years. And what are the risk factors? We all know that most common and significant risk factor is cigarette smoking, and followed by alcohol consumption, betel quid smoking, poor oral hygiene, and certain infections like HPV or Epstein-Barr virus, as well as fungal infection, Candida albicans. And poor nutrition also implicated to be one of the risk factors. So basically these two are risk factors, tobacco and areca nut. Smoked tobacco predominantly consumed in the form of bidi as opposed to cigarette smoking in a developed world. And we know what about the bidi. The carcinogenic effects is seen in head and neck region due to non-porosity and low combustibility of the tendu leaf and lack of filter and high tar content. And on the other, areca nut, which is very commonly consumed in our northeastern part of India, and it recognized to be an important independent risk factor since its habitual consumption may result in oral SMF. We know it is a irreversible condition and it is a potentially malignant condition also. Gutka or zorga without tobacco are known as pan masala. High content of areca nut have implicated in the development of oral SMF also. And this is the distribution of various risk factors. You can see tobacco almost represents 50%, followed by smoking 14%, alcohol 10%, and other risk factors 27%. So there is a high prevalence of tobacco use among head and neck cancer patients in India. So it was the most prevalent risk factor for carcinoma of oropharynx, larynx, and hypopharynx. And tobacco chewing was the most prevalent risk factor for in females, young adults, males, and patients with carcinoma of buccal mucosa. Habit of tobacco consumption in head and neck cancer patient was much higher than those normal counterparts. Alcohol drinking alone was observed in less than 1% of patients as a risk factor. So the diagnosis and staging. So presentation may be clinical, this depending on the anatomic site. And these are the different diagnostic modality. Physical examination is most important. And for diagnosis, biopsy is required. That can be done with brass biopsy, liquid biopsy, FN biopsy, endoscopic biopsy, incisional biopsy, etc. And the viral staining techniques, imaging techniques also required for the staging, which may be ultrasound, MRI, CT, and PET-CT scan also. Spectroscopy also used, and biomarker detection today is very much commonly used testing in any cancer. That includes gene DNA arrays, and ELISA chromatography, PCR, etc. And this is the flow chart because head and neck cancer, it requires multimodality approach. So for history, past medical history, risk factors, performance status, nutritional status, physical examination, thorough oral cavity head and neck examination, including fiber optic examination, and qualitative diagnosis like for tissue FNA biopsy, and for quantitative, which are the defined imaging, and for the molecular analysis and from the pathology, immunohistochemistry used for certain viruses also. And this is a staging we most commonly use for a solid tumor, TNM staging, that represent tumor node metastasis. So I don't want to go in detail. So these are staged accordingly. We know that stage 1 to 2 is early disease, and stage 3 to 4A considered as locally advanced disease that is unresectable, and stage 4B is considered as the unresectable disease that will require only palliative therapy. But the problem is that in India there is a diagnostic delay, and a sequential explanatory mixed method study in South India done in 2016 and 17 shown there is a median diagnostic delay for head and neck cancer around 2.5 months, which impacts survival rate, recurrence rate, cost of treatment, and the quality of life of treatment. And different reasons are system factors such as accessibility, availability, and access, patients benefit on the cause of cancer and concern on long-term treatment, non-affordable healthcare costs, self-remedy and self-medication, low socioeconomic status, low health literacy and life of the patient, and the poor social support. And what are the different treatment options? We use all treatment like surgery, radiation, and systemic therapy. And the primary approach is surgery for the oral cavity cancers, for the early localized disease, and radiation more commonly employed for pharyngeal and laryngeal cancers. And 80% of in patients with a small primary cancer with no clinical nodal involvement or involvement of only a single node, cure rates of over 80% can be achieved with either of this modality. And it is that for advanced disease, where patient is not whether amenable to local therapy, surgery, radiation. If local therapy is possible, then we go for the local therapy. Where local therapy is not possible, then we use for medical therapy, which includes immunotherapy also. Immunotherapy, we see the CPS, that a combined positive score, and the treatment is done according to the CPS score. And early stage disease treatments, factors that guide decision between radiation and surgery, with patient's performance status, expected degree of functional impairment with surgery, patient and physical preferences, tumor location and expertise. And surgery has an advantage of shorter treatment time and minimal morbidity with small tumors, which are available as a treatment option, because we know that head and neck cancers tend to recur. So if surgery is as a first line, we can go for radiation as a second line. But radiation has certain toxicity also. And locally advanced disease, we use multimodal treatment for surgery-based treatment, and if certain pathologic criteria happens, then we offer post-operative chemotherapy or chemoradiation, and radiation therapy also, where for organ preservation, induction chemotherapy is used before the radiation therapy. Surgery, it is nearly 30% of head and neck cancer patients diagnosed at stage 1 or 2 will be treated with surgery alone or radiosurgery, resulting in an 85% probability of survival with 2 years or longer. Not effective for locally advanced cancer, usually a combination of surgery, radiotherapy and chemotherapy is used. At present, open surgery and transfemoral resection are common surgical approach. Transfemoral resection patients recover quickly and the surgery is economical. Radiation therapy is also very important for both as a primary or adjunctive treatment to acquire organ preservation and reinforced anti-tumor effect, often combined with chemotherapy and or targeted agents, and is often used as an adjunctive treatment in early stage to reduce side effect. And different technology, most commonly IMRT is used, intensity modulated radiation therapy. Chemotherapy, it is as adjunctive treatment, is frequently used for patients with tumor, distant metastasis and local recurrence. But the benefit of chemotherapy over the age of 71 years and did not receive any treatment benefit. And chemoradiotherapy combined with induction chemotherapy can be used to support organ preservation, which is important for like larynx, and decrease the incidence of distant metastasis. Research found neoadjuvant chemotherapy can reduce tumor size in head and neck cancer with locally unresectable tumor. And this is the latest treatment armamentarium in medical oncology. This is the immunotherapy. That the advent of immunotherapy has led to a better understanding of the relationship between the immune system and cell death as a result of chemotherapy and radiation therapy. So most among the immunotherapy agents, most commonly used the immune checkpoint inhibitor ICIs. They are the PD-1, that is the programmed death 1 pathway, that is important immune checkpoint exploited by the immunosuppressive cancers, including head and neck cancers, to avoid immune detection. And binding of PD-1 by either its ligands suppresses activation of effector T cells, and both PD-L1 and PD-L2 expression have been reported in those head and neck squamous cell cancer patients. And this is the evolution of PD-L1 expression. And what are the guideline recommendations? The panel recommends, we mostly commonly follow NCCN guideline. The panel recommends immunotherapy, that is pembrolizumab, as category 1 preferred option for patients with metastatic or unresectable recurrent head and neck squamous cell cancer. So it is used with chemotherapy as a first line or as a monotherapy with those higher CPS scores. And the other guidelines like European Society of Medical Oncology, ASTO, that is the European Society of Radiation Oncology, they also recommend pembrolizumab in combination with 5-FU, cisplatin or pembrolizumab monotherapy, those with PD-L1 more than 1 as monotherapy. And the chemotherapy plus immunotherapy, pembrolizumab are recommended when rapid tumor shrinkage is needed. This is the Indian Clinical Practice Consensus Guideline. Pembrolizumab is recommended as a single agent in patient with a CPS 20 or more, and in combination with or without chemotherapy in patient between CPS 1 and 20. Patients with metastatic or unresectable recurrent head and neck squamous cell carcinoma are eligible for first-line treatment with pembrolizumab and chemotherapy. And what are the indications of referral? Suspected cancer patients should be seen by specialists within 2 weeks of primary care referral to aid early detection. NICE 2015 guideline for defined cancer, laryngeal cancer, persistent unexplained hoarseness, persistent and unexplained neck lump, and for oral cancers, when first assessed by dentists, unexplained ulceration in oral cavity lasting more than 3 weeks, persistent and unexplained neck lump, lump on lip or oral cavity consistent with oral cancer, a red or red and white patch in oral cavity consistent with erythroplakia or erythroleukoplakia. And for the thyroid cancer, unexplained neck swelling in the thyroid region. And in summary, lip oral cancer ranked second in the number of new cases in Indian population, and tobacco has been identified as a risk factor in 80 to 90% of patients with oral cancer. Low proportion of patients with head and neck cancer present in early stage. Early identification of high-risk patients is fundamental goal of screening programs, and the treatment approach to every individual patient is guided by anatomical, subsite, stage of the disease characteristics, functional consideration, and the patient wishes. And pembrolizumab is now a standard of care option for the first-line treatment of advanced head and neck squamous cell cancer. Thank you. So these slides are not mine, these are provided by MSD for educational purpose.
I have only one doubt. There is a risk factor. Risk factor of dekhoa goisil je only smoking causes more cases than smoking plus tobacco plus
Smoking
alcohol.
basically associated with not the head and neck, in the upper aerodigestive tract. That we include esophagus, lung part, these are the, but those in the head and neck, this is mainly important to the upper part, that is oral cavity and the oropharynx. So in the smoking mostly implicated as head and neck cancer, but upper aerodigestive tract, that is for larynx. For laryngeal cancer, smoking is a very much risk factor. But these slides are present mainly focused on the oral cavity cancers. For oral cavity cancers, it is the chewing tobacco or pan masala is more deleterious. But if you combine for esophageal cancer, for this is both smoking and alcohol have a equal contribution as a risk factor. So histology difference. So there is one thing also, field cancerization theory. That is because of the inherited nature, if the person develop cancer in one side, that is your head and neck cancer, the person will be susceptible to developing cancer of the, that means upper bronchi or esophagus also, just like bladder. These are different risk factors. But these slides are mainly focusing on the data from your oral cavity and these things.
Thank you, Anupam.
Because oral cavity cancers are almost 50% of cancer of head and neck in our setup is the oral cavity.
So recently there has been a paradigm shift in the understanding of cancer as well as treatment, and you have explained it very well. So we can take one or two questions. If there are no questions, I think we'll move to the next topic. Thank you, Anupam.
Thank you.
Soon.
Lyme.
Lyme actually does not.
Actually, you see, one of my brother was expert into laryngopharyngeal carcinoma. Then when I went to Tata, he asked him, what you are taking more? He used to take card. At present, in some part of the Assam and most of the part of the India, when they are preparing the card, they are mixing the lime. Because lime, when you use the lime in the card, it become more बहुत आथा হয় গতিকে after that they are telling that at present BBC is also has some research
Yes,
about the
lime may be some
Lime
important
is a
factors
radioactive also.
because it is
Most
used
of
in
the
Irrigation.
patients who are taking the polluted card, they are suffering from the laryngopharyngeal carcinoma. Am I correct, sir?
Yes. Lime is also some implicated, and also in Erica nut we use lime as a part of your, you have pan masala or tamul, which we commonly call tamul, pan tamul.
What you are telling about the Bitilnath cancer, I am telling you, when Dr. Suren Sharma was the first principal of the Guwahati Medical College, first his innovative work upon the Bitilnath in Assam and other part of this one, the Bitilnath cancer is more common in the laryngopharynx area.
Yes.
Am I correct?
Yes, sir.
Anupam, any role of fermented products and smoked products? Smoked product, I know, it's a pre-cancer.
This is basically for stomach cancer.
Yeah, and what about fermented products? Is
This
it oncology?
fermented smoke or using preservative like nitrosamine, and for liver cancer, fungal like plant aflatoxin is implicated in liver cancer. So different food items are also implicated, and for those are mainly for your stomach cancer, just like your fermented or smoked product or your
Fermented is different and smoked is different, right? Fermented, like few fermented products, we say it's good for gut. So I'm confused whether we should be using them or not.
fermented. I will
Like
not be able to
hard,
definitely
like
comment.
alkali.
But fermented, I will not be able to make any definite comment. But those preservatives or smoke
course.
product, these are bad for the stomach cancer. Basically.
Okay, thank you, doctor.
Thank you.
Thank you, sir, for your valuable insight on the head and neck cancer. Now, with this topic, we come to the end of this session. I request our chairpersons, Dr. Manisha Deka ma'am and Dr. Aniruddha Deuri sir, to please proceed to the felicitation podium for the felicitation ceremony. And I also request our respected speakers, Dr. Partha Bhattacharjee sir, Dr. Anupam Mohanto sir, and Mr. Ayas to please proceed to the felicitation dais for the felicitation ceremony. I request our chairpersons to please felicitate our speakers, and I request Dr. Bidyut Gogoi sir to please felicitate our respected chairpersons. Now we begin with our next session and the last session. To begin with our next session, I would like to call upon stage our respected chairpersons, Dr. Parmanand Maheshwari sir, Chief Consultant, Department of Anesthesia in the Central Hospital, NFR Maligaon. I request sir to please come upon the stage to chair over our next session. I also request Dr. Emmanuel sir, Senior DMO, Central Hospital, NFR Maligaon, to come upon the stage and chair our next session. Now I would like to call upon stage with the due permission of our respected chairpersons, our next speaker, Dr. Ankur Khandelwal sir. Sir is the additional professor, Department of Anesthesiology, Critical Care and Pain Medicine at AIIMS Guwahati. Sir has been awarded the Professor P.K. Singh Young Anesthesiologist Award in 2022, ISA Young Talent Award in 2023, and also the Best Reviewer Award for JNACC 2024, and also and many more awards to its name. Sir is an ACS certified ATLS instructor. I request sir to please come upon stage and proceed.
Hello. Good afternoon, respected chairpersons on the dais, faculties and delegates of the dais. At the outset, I would like to thank the organizers, especially Maheshwari sir and Somnath sir, for giving me the opportunity to be a part of this lovely conference. And this is my first visit to the railway campus. It's so beautiful. And the food was good too, sir. So kudos to the organizing committee. But then why am I here to speak on ATLS, something deviating from the anesthesiology spectrum? But to a true sense, this is one thing which probably every physician or every MBBS doctors, probably paramedical staffs also should know the basic concepts of advanced trauma life support, how to approach a patient who has come with trauma, that is approach to a trauma victim. So my interest for trauma began in 2022 when I joined AIIMS Guwahati, and then we had ample time because there was no building at that time. So we had ample time to roam here and there for few initial months. And then when I decided that, okay, since we do not have any ATLS center in Northeast India, I will go to some other state, do my ATLS training. So me with my two surgeon colleagues, we went to Goa. We did one ATLS provider course, which is a very, very robust course of 2.5 days, and it's the same course running across the world, same pattern, and it's conducted by American College of Surgeons. So there I completed the provider course and I got the instructor potential. Then within 2 months or 3 months I went for instructor course in JIPMER Pondicherry, and then I got the IC. I did the instructor course again in Goa, and then I became the instructor, ATLS instructor. But then we had some other vision ahead. We decided that we do not have any center in Northeast India for ATLS training. And then we decided that what better platform than AIIMS Guwahati itself take up this initiative and create one ATLS provider center in Northeast India. And we worked very dedicatedly for almost 2 years creating our simulation lab. This is a multi-purpose lab, but then it's a very, very good lab for ATLS. And after 2 years, our site got inspected. It was cleared off with permission, and we conducted our first ATLS course in 2025 December from 12 to 14. And to inaugurate the inaugural course, Professor MC Mishra sir, the former director of AIIMS Delhi and the current chairman of ATLS India, he himself had come, so many other faculties had come, and the course was done successfully. Basically, why I need to emphasize is this: in every course we enroll 16 candidates who can be of any specialty. Just the basic minimum mandate is that you should have MBBS degree, and whether you are a postgraduate, you are a consultant, senior consultant, HOD, all 16 can sit together, and it's a 2.5 day course which is consistent across the world because we follow the same pattern. The first course was very successful, and just last week we completed our second course, second provider course. So in this way, every year we are planning to conduct at least 3 to 4 courses, and I request the railway authorities that you can send your representatives in our hospital for the subsequent courses, particularly the people who are the first responders, like trauma physicians, emergency physicians, medical officers, and I assure that this training will definitely help them just to visualize how ATLS teaches them and how one should approach a patient with trauma. So with this, our next course is in the month of August, but unfortunately, the moment we release our advertise, it's second day it gets filled up. So August course is again filled up with 16 candidates, and now probably we'll have to increase the frequency of organizing these courses. But do enroll when you get the opportunity. Only MBBS degree, you can be of any branch. So with this, I begin my session. I do not have any conflict of interest. Nothing is my personal. It is absolutely from the ATLS manual, and the latest manual is the 11th edition of ATLS released by American College of Surgeons. So everything in the slide is from 11th edition ATLS book. So what is ATLS? What do we teach in ATLS as ATLS faculties, or what we as first respondents, how we should deal with a trauma victim when they come first to us? So the core principle is it is a systematic, a prioritized and a standardized approach to trauma care to improve survival. The only reason is that no trauma victim should die, and we are here to ensure that we all come under the same platform with the same teaching, so that we all can approach the trauma victim in the same fashion. And how do we do it? We do it by early identification and management of life-threatening injuries. So there are basic principles to ATLS. The basic principles are: number one, treat the greatest threat to life first. Life-threatening injuries should be addressed and treated first. Rest, everything can follow. This will not kill you. What will kill you should be addressed and prioritized. Second, ATLS teaches that we are not here for diagnosis. We are here just to address to the life-threatening injuries first, stabilize the patient and refer this patient to the specialist. Whosoever within your hospital, or if your hospital is not equipped with radiological and surgical capabilities, you can refer to the higher center. But what our job is, stabilize the patient by addressing all life-threatening injuries first, and then refer this stabilized patient to the specialist. Rest care will be taken by him or her. A detailed history is not required. What we require is a systematic approach to the life-threatening injuries first. What kills first needs to be addressed first. Follow a structured and reproducible approach. We as ATLS family, we always work in the same pattern. If I have been ATLS trained, if there is another person who is ATLS trained, if I'm just giving him few brief words, he will understand what I mean to say to him. That means it is reproducible. It is very structured. One ATLS person will definitely understand the language of other ATLS person, and that is why ATLS always centers developing a team. ATLS never encourage a solo approach. It always focuses on a team approach. A solo approach won't work in trauma scenarios, a triad scenarios. It has to be a team approach, right? And reassess continuously. This is most important. I'll come to it. Reassess continuously. A patient who is looking good to you at current point of time may deteriorate very rapidly after few minutes, and initial assessment says that okay, this patient is fine, chalo apna kaam khatam ho gaya, ghar chalte hain, ye theek hai. The moment you reach home, you get a call, sir, the patient has deteriorated, he is bleeding, he is now hemoperitoneum, in shock. So a patient who was initially good now is not good. So reassessment of the patient, assessment and reassessment, simple principles. So these principles emphasize prioritization, then diagnosis. I am again emphasizing, as first respondents, it is our not job to make a diagnosis. Kya diagnosis? What is this? No, you treat the life-threatening injuries first, stabilize, and then will come the diagnosis. So something there is in ATLS training, we teach initial assessment. So what is initial assessment? How a first respondent is going to behave with the trauma victim. So something is known as preparation and triage. For example, I am the medical officer in my hospital, and from a very remote peripheral health center, somebody has given me a call that doctor so and so patient had come to my PHC. We did this, and now we are referring the patient to your hospital. Or from a triage scenario, an ambulance person tells me, calls me, says that we have just picked up one patient from the roadside of a road traffic accident, we are coming to your hospital. And then your job starts right now, because he'll take 20 minutes, 15 minutes, and this is known as preparation. You need to prepare. You have been briefed by this ambulance person that this patient is coming. So what is this is known as, it's a pre-arrival huddle. It's a huddle between you, your team, nursing officer, technicians, whosoever with you is there at that point of time. You need to make that atmosphere of creating all equipments, gadgets, whatever you need for resuscitating that particular patient, right? Like you perform introductions, you know each other, you can call your team members by name, you review the case, whatever information you got from the phone, you explain it to all your teammates that he has some thoracic injury, there was breathing difficulty, whatsoever information you have got, you communicate it to your team members. Get your gadgets ready, get your equipments ready, suction, oxygen, laryngoscope, endotracheal tube, surgical cricothyroidotomy, chest drains, Foley's catheter, Ryle's tube, these splints, whatever you want. And based on the information received, whether your setup is equipped enough to deal with that patient or not, or you are also at that phase that you need to transfer. Think about transfer also. So this is the main thing. When you are a first respondent and a trauma patient comes to you, how are we going to approach that patient? Remember, we have to address the life-threatening injuries first. Rest, everything can be taken care of subsequently. And what kills first is airway. Always airway. Airway kills first before breathing. Breathing kills first before circulation. Circulation will kill first before disability. And disability will kill first before environmental exposures. So till date, we had been learning that ABCDE protocol. We all know about this protocol. It's just that we need to emphasize it again and again so we do not miss it. Airway kills first. Till 10th edition of ATLS, it was ABCDE. Only in the 11th edition, there has been a new introduction of XABCDE. And what is X? X is external exsanguinating hemorrhage. If there is any obvious external exsanguinating hemorrhage, that should be treated first. For example, a torrential bleeding from the thigh, some injury has happened, bullet injury or whatsoever, or a crush injury, it's bleeding profusely from side. So you can apply pressure, you can apply tourniquets, whatever you know of or whatever is available. So now the latest guideline says that external exsanguinating hemorrhage needs to be treated first, not the internal, external. Internal will come under circulation. Followed by airway. Airway kills first before breathing. So look at the patency of the airway. Whether this airway is okay or it is threatened. If this is threatened, address the airway first. Do not jump to other things, because the moment you jump to other things, a potential threatened airway will kill the patient. So address first. You need to be sure this airway is patent. If not patent, put a definitive airway tube or do certain maneuvers in a way that airway becomes patent, like head tilt, jaw thrust, whatever you want to do. But ensure that patient is intact, right? Simple maneuver is ask the patient, hey boss, what's your name? What's your name? Kya hua aapko? So if he is able to respond to your query with a loud and clear voice, it itself means that airway is patent, correct? But if it's not patent, say patient has come with head injury, he is in a comatose state, so he is obtunded, his airway is threatened. Do not move to breathing. First put a endotracheal tube, secure the airway. Once you are sure that airway is secured, then move on to breathing. Then you assess breathing, and of course remember, airway always comes with cervical spine immobilization, right? So whenever you secure the airway, make sure that your cervical spine is stable or immobilized by a collar, because until and unless cervical spine injury has been excluded, always think that there is underlying cervical spine injury. And during the intubation also, make sure you take adequate precautions not to misalign cervical spine. So airway comes first. If airway has been treated well, addressed, patent, fair enough. If not patent, put a definitive airway. Then move to breathing. See for chest expansion, chest movement, auscultation. If there is any desaturation, if yes, look for what may be the obvious cause. In a trauma patient, most of the time it is hemothorax. It may be pneumothorax, but most of the time we think it to be hemothorax. In doubt, always put the ICD. Do not jump to circulation without addressing breathing. If breathing is proper, chest movement is fine, air entry is fine, there is no episodes of desaturation, fair enough, move on to circulation. But then if you move on to circulation without addressing a pneumothorax, once you start looking over the circulatory cause, the patient will wind up. So do not miss breathing. Once you have addressed breathing, move on to circulation. Circulation means look at the blood pressures and look at the potential sites of bleeding. What are the potential sites of bleeding? It's the thoracic cage, the peritoneal cage, the long bones, right? And back of the patient, right? So we always inspect the back of the patient where there is some external injury or not. So thoracic, peritoneal, long bones and back of the patient. Look for circulatory cause. And here comes the role of, in advanced medicine, here comes the role of, you can, if you have manpower, you can simultaneously do an ultrasound, that is focus, and see whether there is blood in the abdominal cavity or not. If yes, just stabilize the patient, inform your surgeon, take the patient to the theatres, right? So circulatory cause, and then comes the disability. Disability means you have to do a focused neurological examination by assessing GCS, pupils, and whether this patient is having any deficit or not. And then you move on to exposure and environmental control. Exposure means you completely expose the patient to look for any other injuries of the patient. And then environmental protection means you prevent hypothermia because hypothermia in a trauma victim, it's a bad thing. It leads to coagulopathy and delayed effects of the drugs. So remember, the sequence is exsanguinating external hemorrhage needs to be addressed first and treated, followed by airway, followed by breathing, circulation, disability, and exposure and environmental control. There cannot be any breach in the sequence, and that is why ATLS training is so important. It makes you emphasize and re-emphasize again and again that, boss, this is the sequence. Do not bypass any of the track. So once you are rapidly done with A, हाँ देख लिया ठीक है बढ़िया, B देख लिया ठीक है, circulatory ठीक है. Once you are done with A, B, C, D, E, then comes adjuncts. Adjuncts means something which is extra beyond the primary survey. That if till now if you had not attached the monitors, do certain exam investigations like sugar, you can do ABG, you can send the blood for hematocrits and other examinations, and 2 tubes, 2 lines, right? 2 wide bore cannula, which is mandatory because you need to infuse fluids to maintain your circulation, and then 2 tubes. 2 tubes means Ryle's tube and a Foley's catheter, because how will you assess your circulatory parameter? Once you give IV fluid, you need to assess it with urine output, right? Especially in a peripheral setups. So 2 tubes, 2 lines, and some basic investigations you do. And here comes the role of ultrasound. Just do an ultrasound on the chest, see whether there is any potential pneumothorax or not. It hardly takes 30 seconds to do a chest ultrasound. Abdominal ultrasound, look for the 4 cavities. What are the 4 cavities? The pericardial cavity, to look whether there is any cardiac tamponade or not. The right side, to see whether there is any blood in the hepatorenal pouch or not. Left side, to see whether there is any blood in the lienorenal pouch or not. And the last is the pelvic collection. So just put the ultrasound probe in the 4 areas, see whether there is any hypoechoic collection or not. You need not make a diagnosis, you just need to say fast positive. Fast means focused abdominal sonographic test. Fast positive, fast positive, rest will be taken care of by the specialist. Right? Our job is to make a certain initial assessment and stabilize the patient. So once you are done with the primary survey means X, A, B, C, D, E, stabilize. एक बार आपने पूरा पेशेंट को स्टेबलाइज कर दिया. Now his circulatory parameters, breathing parameters, airway parameters, everything is fine. Then you do again a secondary survey, because there are certain things you might miss in the primary survey, because primary survey jaldi करना होता है, because it has to be done within the golden hour, preferably within the platinum minutes. So because you are in a rush, you are specifically looking at X, A, B, C, D, E, there are certain things you might miss in the primary survey. So come again to the patient, start a head to toe survey, pura top to bottom, again examine and inspect the patient. Kahin kuch miss to nahi ho gaya? Have I missed anything? And do a reassessment again. That is what ATLS emphasizes. Take some basic history if you had not taken, because in primary survey we do not mention about taking histories, because that will be a wastage of time. Primary survey is just about stabilizing the patient. In secondary survey, now you can take a brief history from the patient, if the patient is in that condition, or you can take it from the attendants, right? So once you are done with primary assessment, adjuncts, secondary assessment, adjuncts, stabilize the patient, and then there are certain critical concepts of addressing a trauma patient. First inspection and first assessment doesn't complete your job. Patient may get deteriorated after some time. And that is why it is said that trauma is a dynamic situation. It's a very, very dynamic situation. That is why ATLS stresses continuous reassessment of vital signs, response to treatment and new findings. Deterioration will again ask you to come back to the primary survey. अगर patient deteriorate हो गया, straight away come back to the primary survey. Again look X, A, B, C, D, E. So assessment and reassessment. Next is all about team dynamics. As I mentioned earlier, you can't be in a situation of managing everything alone, either to an individual or to a bunch of patients coming to you. No, you need to have a team dynamics. You need to have a team where you can assign one as a leader and then others as important team members, where you can assign them clear roles and responsibilities, just the way we do in BLS and ACLS. Define the roles, what they are supposed to do, so that during the actual management of the case, they don't, all three of them will keep on doing the same thing. No, it's not like that. Everyone has been assigned a role, so that everyone is doing what they have been asked to do, and there is a close loop communication. And believe me, what needs to stand at the end of the day is mutual respect for each other. ऐसा नहीं है कि 4-5 पेशेंट आ गए, आप घबरा गए और आप कभी सिस्टर पे चिल्ला रहे हो, कभी टेक्नीशियन पे चिल्ला रहे हो, उस पे चिल्ला रहे हो, उस पे चिल्ला रहे हो, अपना सबऑर्डिनेट्स पे चिल्ला रहे हो. No, this will not work. What will work is mutual respect, and it comes with once you have created a team and then you start trusting your team. Otherwise, things will be difficult. So trauma systems, the ATLS 11th edition is now emphasizing on the pre-hospital treatment. Till now we had been focusing on treatment starting from the hospital when you are a first respondent. But then nowadays a concept of pre-hospital trauma resuscitation, right at the scene, when you are resuscitating right at the scene. And who does that? The paramedical staffs. And who will train them? It is our responsibility. So every individual, what ATLS says, every individual is a potential lifesaver, provided you just teach him at least the basics. He will come out with some maneuvers to save the patient. So pre-hospital to hospitals, then see whether you have that capability of surgical capability, radiological capacity of managing this patient or not. If not, do not waste patients' time in your hospital. Again, very important concept. Patient के साथ आपको नहीं खेलना है. अगर आपके पास facility नहीं है, your job is to transfer this patient to a center which has all those capabilities. For example, you have brought a patient has come to you, you have now done X, A, B, C, D, E, you have stabilized the patient. And with a clinical suspicion, you have realized that this patient is suffering a head injury. And now you don't have a neurosurgeon in your hospital. Then what is the point of putting the patient to CT scan? What is the point of putting the patient to MRI scan? Aren't we wasting patients' time? We are wasting patients' critical time. If the management doesn't change with our investigations, why are we doing it? We are not supposed to do it. We are not supposed to waste patients' time. We are supposed to refer him as early as possible to a center which has those capabilities after stabilizing. So transfer to definitive care. If your setup is having all those capabilities, keep the patient and go ahead, transfer the patient to your specialty or super specialties, whosoever is capable of dealing with that injury. So stabilize the patient, and if these patients require transfer, then you need to have a clear communication with the receiving authority. Dr. Saab, we are sending this patient to your hospital. I received this patient at this time. The scenario of the patient was blah, 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 blah. we have done this for the patient. Now this patient is stable, but we do not have these capabilities. So we are now referring the patient to your hospital. Mention the injuries, mention the treatment you have given to the patient, so that now they be prepared. They can have a pre-operative, pre-procedural huddle. Okay, we got this information from this hospital. Now we need to get ready, so that पूरा loop में patient doesn't lose vital time. So there is a structured approach to how you give communication to the receiving authority. It is by S bar, the very popular mnemonic S bar. S means situation. You tell everything about name, age, where did you get this patient from, what were the indication of transfer, then X, A, B, C, D, how have you managed it, what was the background of the patient, what was the assessment, and what are the recommendations from your end to be done by this team, right? But do we really think that our job is done? Our job is done even if we have kept that patient in our hospital. Do you think just X, A, B, C, D, addressing to X, A, B, C, D is over? No. But now what ATLS does, ATLS clearly says that your job is to stabilize the patient, X, A, B, C, D, E. But then there are certain trauma sequelae in the future, like lot of mental, trauma, psychological, all those disturbances are there in the patient, right? So behave with the patient in a way that the patient is so prestigious to you. Make the patient feel comfortable, make the patient realize, be empathic to the patient, right? And that is why please promote patient dignity. Very, very important. Do not discuss anything with the patient which is irrelevant for the case management, right? And the last slide, again ATLS 11th edition focuses on injury prevention, because we as doctors, we need not focus specifically on treatment part. Treatment is okay. Patient has come to us. We have to treat. But then why do all require treatment if prevention can be done effectively, right? So we as medical fraternities, it is our job to do certain programs, community outreach programs, some videos on social medias on awareness. So all this, everything counts. So you can do programs in the community, you can create your own videos, you can write articles for the newspaper just to create awareness, because prevention saves more life than what treatment does. This is the whole crux of ATLS. And key trauma errors to avoid: do not miss compromised airway. I'm telling again and again, because it happens by instinct. It happens. Suppose an orthopedician has been deported at the emergency area, so by virtue, no, it happens, a trauma victim has come to him, and then there is hemopneumothorax, there is some airway injuries, and there is some obvious leg deformity. Being an orthopedician, he will always focus more on the deformity in the leg. So he will start stabilizing the leg, putting a splint, all those things. Even if there is a laceration, he will start biting the laceration. But then what thing has gone wrong? The thing that has gone wrong was that his airway was compromised. That should have been addressed first. He had hemopneumothorax, ICD should have been put first, and then later on he could have come to the bones. Bones will not kill first. Airway will kill first, breathing second, then circulation, and so on. So the focus is on X, A, B, C, D, E, and there cannot be any breach in this sequence. Treat first, investigate second, save the life of the patient first, and then do whatever you want to do. So take home messages, clinical principles, it's across the world, it's being followed, same XABCDE, continuous reassessment, teamwork building, resuscitation principles, early blood transfusion. So activate your blood bank as early as possible. The moment you realize that this is a circulatory cause, avoid fluid overload, prevent hypothermia, avoid hypoxia and hypotension, which are the independent predictors of morbidity and mortality across all groups of trauma victims. Hypotension and hypoxia, don't you agree? Absolutely, we agree. Right? Correct blood pressures, correct breathing pattern and airway. Hypotension and hypoxia, 50% of your job is done. Right? And make sure if your setup is not equipped to handle the patient, stabilize the patient and make early transfer. Do not waste patient's vital time in your hospital. Please do not do. There are many other hospitals who are willing to take that patient. Treat the greatest threats first, investigate second. Thank you so much for your patient listening.
Sir, I have one question. I am anesthetist, Dr. Ravi Kiran. It's always said ABCD, but 11th edition added XABCD. But still the funda I am not able to get cleared. Why to concentrate on exsanguinate?
Because there are potential sites of exsanguinating external hemorrhage which can bleed profusely at times, say 1 to 1.5 liters. So, and it can be addressed very quickly just by putting pressure or by applying bandages or by putting tourniquet, and then you can move on to airway.
Major arterial bleed
Yes.
has to be addressed
first
before airway.
External, yes.
Yes, sir. Thank you, sir.
Thank you, Ankur, for your brief and crisp presentation.
Thank you, sir.
We do in railway, we do have a infrastructure for accident, attendance, but our infrastructure is quite archaic and we need to improve it. And your point regarding collaboration in training is well taken. I think we'll take with higher ups. And now if you have any question.
Sir, what I emphasize is that send your residents, send your medical officers and whosoever is interested. I assure you, once they do the ATLS, they develop that mind of developing your own institute. They will come back and then they will start planning how to develop, like we did.
Correct.
We went there and suddenly ATLS course, it opens your mind. My goodness, what is this? Let us try in our hospital, and today we are doing it. So your residents will then develop a mindset, नहीं हमको तो करना है, हमारा सेंटर को भी हम ऐसा बनाएंगे. ATLS teaches you that, sir.
Any question?
Sir, ATLS doesn't require infrastructure. As I mentioned, just X, A, B, C, D, E. Later on, if your hospital is not equipped, you can transfer. What we are emphasizing is that stabilize the patient by addressing the life-threatening injuries first. Stabilize, later on you can transfer. But what happens if the patient is not stabilized? He will die anyway. So at least first stabilize, later on if your hospital is equipped, good enough. If not, transfer so that other hospital can manage. पेशेंट का जान बचाना है सर, कैसे भी करके आप बचाओ, वो बचाए, कोई भी बचाए, सेम प्रिंसिपल फॉलो करके जान बचाना है, पेशेंट मरना नहीं चाहिए.
Sir, you mean simply there is no need of any equipments, just our hand and watching with the eyes and other things.
I agree, sir. Basic equipments, yes. Just basic equipments.
Basic equipment means. What do you want?
It's not specifically focusing on the equipments. What ATLS teaches is on the approach. What is the right kind of approach to a patient with trauma victim? That's it. With the bare minimum equipments, at least you can stabilize the patient.
Only bandage and trial.
Cervical collar, intubation, chest drain, that's it. Circulation you can manage.
Okay.
I would like to highlight our DMO from Rangapara, Pruthu. He himself has prepared a basic kit for trauma runover. So, it based on the requirement, preparation can be done. So,
Absolutely, absolutely.
Actually, I worked so many years in casualty. Only suppose one or two person is completely ATLS trained. We are having equipment also. But basic is that with the equipment and ATLS trainer, basic is the manpower. Suppose there is a railway accident, 20 number of patient is coming in the casualty, you need a manpower. Just enough sisters, nursing staff, enough attendant, enough dresser, all this manpower is immediately needed.
I agree. I absolutely agree, sir.
Sir?
I agree to you.
Yes, sir. If somebody may be expert in ATLS, somebody may be expert 1 or 2 person, he need all kind of specialties and dressers, attendant, then at least 2 to 4 attendant. Not only one attendant cannot cover. So these are the basic things we need. Manpower is most essential.
I agree, sir. Absolutely, manpower is needed. But then if 20 patients are coming to you, then it becomes very imperative to understand which kind of patient needs first treatment. Who is the patient who needs to be addressed first? All 20 patients may not be that kind of serious. Who is a potentially salvageable patient needs to be addressed first. Rest, okay, I'm coming to you one by one, but let me address this patient first. XABCD, tuck, 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 XABCD, tuck, 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 XABCD. Later on, of course, you need manpower to transfer these patients to specialized areas.
Sir, what about pain management? Is it not important?
It is important, definitely important, but then it doesn't take a priority over XABCDE. Pain will not definitely kill the patient, it will make the patient distressed. I agree, but then life-threatening injuries have to be treated first, XABCDE. Later on adjuncts, secondary survey when you are doing, okay, this patient is suffering from pain also. You can give some analgesics, you can put some local blocks, whatever you want to do. But then life-threatening injuries to be addressed first.
Thank you, Ankur. With this, we wind up.
Thank you. Thank you so much, sir. Thank you so much.
Thank you, sir, for your short and very informative session on ATLS. Next, I would like to introduce our next speaker. It is my great privilege to introduce Dr. Priyam Saikia, sir, our distinguished academician and clinician, currently serving as a professor at Guwahati Medical College. Sir has consistently demonstrated excellence in both medical education and research throughout his illustrious career. A gold medalist in his final MBBS, he has upheld the same standard of dedication and brilliance in his professional journey. With over 30 peer-reviewed publications to his credit, Sir has made significant contributions to the field of anesthesiology and medical science, and has been awarded the Best Peer Reviewer Award from the Indian Journal of Anesthesia, and has been honored by the ISA Assam State Branch for his outstanding academic contributions. I invite Dr. Priyam sir to please speak on this topic.
Yeah, thank you so much, Dr. Sanchita. It's so nice to see you after so many years. A very good afternoon to the chairpersons, and I'm grateful to the organizing committee for giving me this opportunity to speak on perioperative anaphylaxis. I'm thankful to Dr. Ankur. I did ATLS around 12 years back, and after 12 years, today I came to know that it has been changed. So this is the beauty of coming to Railway Hospital, attending a CME, and restructuring your brain again. And I must tell you, ATLS is one of the course, that has opened a lot of avenues for me. And I don't have any conflict of interest with ATLS, but if you get an opportunity, please do ATLS course. Thank you. Sorry, I have to get my timer on. Yeah. A very good afternoon to you. In next 15 minutes or so, I shall be touching a brief overview about perioperative anaphylaxis. I don't have any conflict of interest pertaining to this presentation. For your treatment strategies, kindly please refer to your local institutional or your regional guidelines. In next 15 minutes, we will go touch almost like what is the definition, pathophysiology, a little bit about the clinical presentation, how these are treated, and what to do in a post-event scenario. So these are the things that I plan to touch. The reported incidence of perioperative anaphylaxis is quoted to be around 1 to 2 per 10,000, but it has got a case fatality rate of 4%, so that is quite high. The problem is that most of the signs and symptoms traditionally that we know of anaphylaxis are masked either by anesthesia or they are influenced by the concurrent medical issues that the patient might be suffering from. Thus, there is a delay in diagnosis as well as there is increase in adverse outcomes. The definition of anaphylaxis has been changed recently. This is a definition given by World Allergy Organization. They say that anaphylaxis is a severe life-threatening systemic hypersensitivity reaction which is characterized by rapid onset with potentially life-threatening airway, breathing, circulatory problems, and is usually, but although not always, associated with skin and mucosal involvement. So, by principle, we are talking in terms of just the way Dr. Ankur was telling us that A, B, C, D, E, except we will not have X here. Now, what is hypersensitivity? Recently, hypersensitivity has been defined that it's an umbrella term to cover all unexpected but reproducible reactions to exposure to a defined substance that are tolerated by normal individual, but that go beyond the primary pharmacological actions if we are talking in terms of a drug. Suppose it's a venom, then it's a different issue. The mechanisms we all know that in anaphylaxis, the mast cells and the basophils, they undergo degranulation. The classical pathway we all know, I am exposed to an allergen, I develop IgE, then subsequently when I will be exposed to that allergen, that IgE allergen combination will cause the mast cell or the basophil to degranulate. But nowadays we have come to understand that there are some other mechanisms also. For example, the non-specific mechanisms, like by direct stimulation, by drug, for example, atraquirium, mivacurium. We all have seen that in our clinical practice. We give atraquirium, slight flushing, no issue. It is not anaphylaxis. It's just some histamine release. Then it may be because of complement activation. For example, contrast media and protamine, they can cause complement activation, thus leading to degranulation. And nowadays we have come to understand that some neuromuscular blocking agents, as well as some opioids, they act through a pathway that is known as the MRG-PRX2 pathway. And very recently, this has been given very importance that this is a pathway that may be relevant for anaphylaxis that we see in and around perioperative period. But whatever the mechanism is, that ultimately there will be degranulation, which will lead to vasodilation and all other subsequent, clinical presentations of anaphylaxis. Anaphylaxis is a clinical diagnosis, and that is a diagnosis that is to be made during an emergency procedure. So this is one of the most commonly quoted diagnoses. Give us the premise for diagnosis. Number one, either it is an acute onset of illness from minute to several within simultaneous involvement of skin or mucosal membrane with at least one severe symptoms. For example, there is respiratory compromise, or there is reduced blood pressure, or there is severe gastrointestinal manifestation in terms of severe abdominal cramp, etc. Or in absence of that, it is an acute onset, either hypotension or laryngeal involvement in terms of stridor, voice change, or odynophagia, or it's a bronchospasm when the patient is exposed to a known or a highly probable allergen. So any one of these definition would work during our day-to-day practice if I think that any clinical deterioration is because of an anaphylaxis. Previously, we all knew that hypersensitive reactions are classified into 4 categories, but nowadays they have been divided into 5 categories. I will not go into details of it because of lack of time. But what we need to understand is that if there is any severe symptom is present or moderately severe, that is grade 3, 4, and 5, those are only labeled as anaphylaxis. Other mild or limited, symptoms limited to a certain area, those are now classified as grade 1 and 2, and those are not termed as anaphylaxis. Now, NAP6, which is a United Kingdom audit where they are, Anesthesia Society, they have looked into the cases of anaphylaxis. I think there were 266 cases, out of which around 190 or 199 or 200 cases were because of definitive or highly probable anaphylaxis. What they have found is that the clinical presentation is, it's not something that we encounter in our day-to-day outside OT anaphylaxis. Hypotension and bronchospasm or high airway pressure was the most common presenting feature, as well as this is a feature that was present throughout. Very interesting thing is that a few patients are present with bradycardia, if you can see the slide, and very important thing is that many patients are presented with decreased EtCO2. All anesthesiologists will know what is a decreased EtCO2 or an absence of EtCO2. So this is very surprising. But let us understand that the manifestation or clinical presentation of anaphylaxis would depend on what are the comorbid diseases, what is the surgical pathology. Definitely a patient having a carcinoid tumor would present differently. Or what is the anesthetic technique? Is my patient under GA? Is my patient under spinal? If it is under GA, what are the drugs that I have been using? And it is depends also on the surgical technique. Suppose a patient who is undergoing laparoscopic cholecystectomy, the presentation of anaphylaxis would be a little bit different, or the time, that temporal time would be different if that same patient would have been undergoing an open cholecystectomy. So all these things we need to consider while dealing in a patient with suspected anaphylaxis. I'll spend some time on this slide because we always learned that anaphylaxis is because of severe vasodilation, that hypotension that we see in anaphylaxis is because of severe vasodilation. So the systemic vascular resistance goes down and the blood pressure goes down. And there is a massive sequestration of fluid in the interstitium. There are some studies that tell us that within minutes up to 70% of blood volume can get sequestrated. But now we have started to understand is that there are a very good subset of patients where these two only are not the pathophysiological mechanism. Now we have started to understand is that there are a group of patients who develop Takotsubo cardiomyopathy. That is the cardiomyopathy, instantaneous cardiomyopathy that we get because of stress. And here the stress is not your mental stress, here the stress is your allergic reaction. Second group of patients, Kunis syndrome. That is there are different types of Kunis syndrome. There is a coronary vasospasm that occurs because of anaphylaxis. But a very important thing is that even in a patient with normal heart, when the heart is underfilled because of vasodilation and fluid sequestration, and we are giving epinephrine, the mitral valve leaflet, anybody who has done basic echo would know that mitral valve leaflet will go and touch the interventricular septum during systole. That is going to cause left ventricular outflow obstruction. So that is called a SAM, that is systolic anterior motion of the mitral valve leaflet. That can also be present. So there the treatment modality is different. So what I want to say here is that only vasodilation and fluid sequestration may not be the reason behind hypertension, and this is what we need to remember. There are lots of differentials. What are the differentials that would depend on whether you have encountered in your OPD practice or you have encountered in your OT. So we will not go into details of that. The working group of Japanese Society of Anesthesiology in a recent, publication, they have given this, image to help us to go through to understand what are the differential diagnoses of anaphylaxis. But what I find is that it is a very difficult diagram to use during an emergency, right? So I try to find out, is there any other recommendations? Now, as Dr. Ankur was talking about a team approach, the Australian and New Zealand allergy group, along with their anesthesia society, has given us the team approach. What they say that during anaphylaxis, you have got a leader who would just see and do, ask people to do it. One is a reader. and that reader would read 4 or 5 cards, and this is an example of a card, and the other people would do the job. For example, suppose a patient is presented with cardiac arrest, then he would or she would read that these are the differences of cardiac arrest, and the person will act. Suppose instead of cardiac arrest, the patient is presented with high airway pressure or bronchospasm, so these are the differential diagnoses. This is freely available. We can download it, we can print it. So what does it say? That you use that card, you keep that card in OT, and let just somebody read it. Now, a very brief point about etiology. That NAP6 that I was talking about, they have found out that in around, the majority of the patients, the anaphylaxis was because of antibiotic. And the second category was because of neuromuscular blocking agents. Rocuronium and succinylcholine were implicated. And very interesting finding is that chlorhexidine was the third number. And blue dye that is used during oncological surgery was in number 4. But what we need to understand is that there would be some institutional, regional, or geographical variations, because the type of drugs that we use would be different from the type of drugs that is used in UK. We would be using some other antibiotic, they would be using some other antibiotic, but it gives us a pattern, right? And we should also understand that one single medical device can have different allergens, right? Now, it has been seen that around 80% of those events have occurred in and around induction. 13% have occurred during the mid-flight, that is during surgery. And most of these patients have presented within 5 minutes. But let us understand that there are some delayed triggers. That means the exposure might have occurred now, but the clinical manifestation would occur in and around later on. For example, chlorhexidine, patent blue dye, Sugamadex, latex, all those were delayed triggers. So that is why they say that anaphylaxis is an acute illness where the exposure has been within minutes or in last 1 or 2 hours. Okay. Now just one slide on neuromuscular blocking agent as a source. Neuromuscular blocking agent sensitization may have occurred from our household exposure. I may have been exposed to it because there are various substances. They share the quaternary ammonium compound which is there in the neuromuscular blocking agents. That is the reason why if a person is reactive to vecuronium, that person can very well be reactive to atracurium. So let us not be in a false sense of security that that patient was allergic to vecuronium. I will use atracurium. That may not happen. A very interesting finding that was seen is that children, the anaphylaxis rate is similar, but in adult female, with due respect, the incidence is higher, and they thought that it is because of more exposure to cosmetics. And in 2007, Norway is the country who have banned fall codeine containing cough suppressant, and now they have seen that the allergic response to neuromuscular blocking agent has gone down. Now this is another card that shows what is to be done during an anaphylaxis. Because of lack of time, I will not go into details of that, but just let us understand is that the treatment of anaphylaxis in an otherwise situation is IM adrenaline. But because we are talking here about perioperative anaphylaxis, most of us, we would use an IV adrenaline. Now, different guidelines will give you different doses, but most of them, they agree that number one, less severe reaction, go ahead with lesser adrenaline. For example, moderate reaction, 10 to 20 microgram IV. Severe reaction, go a little bit higher, 50 microgram. Japanese society say go ahead with 0.2 microgram per kg. But the basic principle is start from low, then keep on escalating. And if you need to use more than 3 doses of IV adrenaline, please label it as a refractory anaphylaxis and you escalate. Escalate how? Number one, treat the resistant hypotension. They recommend go ahead and add vasopressin 1 to 2 unit IV, and then you escalate the vasopressin infusion up to 2 unit per hour, just like normal other shock. And then you consider adrenaline infusion or noradrenaline infusion depending on your clinical circumstances, and consider using invasive monitoring, arterial line, your bedside echo, everything, just to understand what is the pathophysiology. And we know that bronchospasm has to be treated, and we know how it is to be treated, and the trigger has to be removed. Sir, may I be allowed 2 more minutes? Yes? Okay, thank you. A very few interesting things that we have learned from NAP 6 is that number one, if a patient has presented with cardiac arrest in anaphylaxis, go ahead with ACLS. I think Dr. Biswajit would be speaking on ACLS. But in cases of anaphylaxis, if the systolic BP is around 50, go ahead with CPR. Go ahead with CPR. So this is very interesting that they say that go ahead with CPR even though the patient is not in cardiac arrest. This is what is very interesting. And they have said that in certain categories, the risk of mortality is very high. For example, patients who are elderly, ASA category 3, on beta blocker or on AC inhibitor, you escalate your treatment. Escalate treatment in the form of give adrenaline, escalate adrenaline, give fluid, escalate fluid, and escalate your monitoring devices. We will not go into details of airway management. Just let us understand that if a patient has got a supraglottic airway, remove and give a tube. And intubation should proceed along with fluid resuscitation and adrenaline. Please do not delay airway maneuver in this group of patients. This we have already discussed a little bit about the cardiovascular collapse. We will not go into details of that because of lack of time. But it's a very interesting thing is that those patients who are presented with bradycardia, their mortality is very high. And what they have seen that if we have given atropine or glyco-induced group of patients, 1/3 of patients have died. And the cause of bradycardia is just like your spinal induced bradycardia, severe hypovolemia. So what they have recommended is if a patient with anaphylaxis is present with bradycardia, go ahead with lots of fluid and go ahead with early adrenaline. Do not consider atropine. This will give you a false sense of security. And once your the problem has been managed, let us also understand that many of these allergic reactions are biphasic and they will present to you later on. So shift the patients to ICU and monitor for at least 24 hours. Remove the offender. The offender can be a central line, the offender can be a dry tube, the offender can be a drug, the offender can be the ventilator circuit. It can be anything. So just go through it and identify the offender if possible and then remove it. Once the patient acute phase has been controlled, what they say that now you can consider steroid if you want to. You can go ahead with dexamethasone if you want, you can go with hydrocortisone if you want, that's fine. But there is no role of IM or IV antihistaminics. If the patient can be given oral antihistaminic, go ahead. And immediately, number one, if your facility is there, send immediate sample for serum tryptase. Then within 1 hour, send another sample because by 1 hour it is supposed to peak. And then at 24 hours after stabilization, you send because the 24-hour value would give you the baseline. So then we will retrospectively see how much was higher at the first hour and it will help us to conclusively diagnose that it is a patient with anaphylaxis. So last 2 slides. Now, suppose anaphylaxis occurred and we have controlled it. So what do I do with these patients? This is a diagram that is given by a society. It follows our common sense, what to do. So we will not go into details of that. But what we must understand is that accurate culprit identification requires specialist test and we are not equipped to it. So once the crisis is over, write down nicely, write down everything and send the patient to a specialist center or the allergist. They will do the allergy test, they will interpret because it is very difficult for us to interpret. Based on their interpretation, let us formulate and repeat anesthetic plan again. So that is what the guidelines are recommending. The last slide is that what do I do if a patient had a previous history of allergic reaction? What they say is that an uninvestigated preoperative anaphylaxis is the only risk factor. Otherwise, nothing else is a risk factor. So that means all perioperative anaphylaxis should be evaluated. Second point is that suppose the patient complains that I have got a NSAID-induced asthma, avoid it. If a patient has got an alpha-gal syndrome, avoid gelofusine. Sorry, that's a brand name, a gelatin-based solution. If a patient has got egg allergy, no point in avoiding propofol. Seafood allergy, no point in avoiding protamines and all. And there is no need to modify standard perioperative protocols in alpha-gal syndrome except gelatin-based products. So my take-home message is that Anaphylaxis, perioperative, often presents without skin manifestation, simply as an isolated cardiovascular or respiratory collapse. Adrenaline, if possible IV, we are trained to do it, 10 to 20 microgram or a little bit higher as a first line of therapy. If systolic blood pressure is less than 50, please proceed ahead with CPR. Do not wait for the patient to go into cardiac arrest. Read the card. So we need to have those cards in our OT printed. Only 4 or 5 cards are there. Remove the potential allergen. Refractory shock may require other agents beyond adrenaline. So let us just arrange those things. And anticholinergic, they treat heart rate. They do not treat anaphylaxis. So if a patient is presented with bradycardia, please go ahead and give them fluid, serum and epinephrine. Serum tryptase sampling is essential, but normal value do not exclude it. Let us take help of an allergist to understand that. But at the end, all patients will require allergy referral, structured post-event investigation, documentation, and counseling. So prevention, it depends on multidisciplinary collaboration between you, the surgeon, and the team and the allergist, pharmacovigilance, as well as standardized post-anaphylaxis pathway. Thank you so much.
Thank you, Dr. Priyam Saikia, for addressing a very important situation we face in anesthesia. I was just, before I open to the delegates, I was just wondering how the chlorhexidine is involved. Because chlorhexidine is there in hand drops also.
Yes.
Chlorhexidine is there
in those central lines also.
Central line
The
also.
chlorhexidine in central lines also there. Yes.
Yeah. Then where is the exposure normally?
No, during skin preparation only.
Skin preparation?
Yes, during skin preparations, or there is a very beautiful article, case series that has been published in some anesthesia journals, where they have shown us that a patient came to OT, renal transplant. I exactly remember that. Renal transplant, central line given, patient collapsed. They could not diagnose anaphylaxis. They thought it is something as pneumosumo. Then they thought it is anaphylaxis. They have treated. And again, when the allergy test was done, it was negative. Again, when they tried, maybe 1 year later, again during central line, the same event occurred. Subsequently, when they read the medical reports, then they thought that chlorhexidine might be a culprit. Then the allergists have evaluated for chlorhexidine. So that was a very beautiful case report, and they have published case series. I'm forgotten, but I think there are 6 case series from USA where they have shown that chlorhexidine is the culprit, and that is what was observed in the UK data also. But we have not observed it here. We will have to understand why it has not happened here. Maybe we have missed, maybe, our genetic build-up is different. But UK, they have identified that chlorhexidine is an issue.
Sir, in anesthesia practice,
yes,
when there is an hypotension, commonly we are using ephedrine by 6 mg by increasing the dose. In anaphylactic hypotension, shall we use this ephedrine?
So I could not understand what you have used.
In anesthesia practice, during the hypotension,
yes,
commonly we are using ephedrine.
Ephedrine, yes, yes.
In anaphylactic practice, when there is an hypotension, you said adrenaline 10 to 20
Yes.
starting.
Yes.
Shall we give this ephedrine in anaphylactic shock?
Yes, sir. If you can see the fourth, of the
Not
fourth.
visible, sir. You are not seeing. You
Right.
tell me, sir.
The thing is that adrenaline is the treatment of choice. There is no question about it. Absolutely no question about it. Even if it's an anaphylaxis shock, you have got ephedrine, you will have to go ahead with adrenaline. But later on, if you think that the patient is not getting, managed with that, and you do not have access to either to give adrenaline as an infusion, you may not have access for that, or you do not have access to noradrenaline, or you do not have access to phenylephrine, then you can also go ahead and use mefentermine or any other
Ephedrine.
Yes, ephedrine also. It can be used, but never the first line, and it is to be used after you have added ephedrine, and it is mentioned as a treatment modality for refractory anaphylaxis. That means the patient has not responded for 3 doses of anaphylaxis. Sorry, I mean adrenaline.
So, second question.
Yes.
For bradycardia, we are using commonly atropine.
Yes, sir.
But in this case, you said we have to increase the fluid. How, sir?
No, sir, I have not said it is what the guidelines are saying. Now, what they have found out, that NAP6 they have found out is that a sizable number of proportions, these patients would present with bradycardia. Now, we have not gone into details of those cases, but normally this is my presumption. I have not read those case reports. Most of the time, either the vasodilation is so massive, so sudden, or the patient has deteriorated for some time that we did not notice that. We somehow missed it. So that patients, they go into a decompensated phase. That is a basal-celiac reflex that we all know. Because of vasodilation, the right-sided atrial receptors, they do not sense that, they are being, there is volume inside the right atrium, and that is what causes the bradycardia. So that is a reflex mechanism. So what they have seen is that all these patients who are presented with bradycardia, they have got good hypovolemia. That means good amount of fluid was not given to them. So what they have recommended is that there is a physiological rationale behind it because of basal-celiac reflex, and there is observation that they did not receive fluid. Based on these two, they have said that you go ahead and resuscitate this patient. Another observation that they have noted was that those patients who were given atropine, 1/3 of these patients, they subsequently died of cardiac arrest. What they have thought is that because when we give atropine, we think that the bradycardia would now be treated. And we were a little bit reluctant to institute the treatment which was necessary. The treatment which was necessary was adrenaline and fluid. Right? So we would be a little bit reluctant. That is the reason why they have said that if you have a patient of anaphylaxis with bradycardia, don't go ahead with atropine, go ahead with fluid and adrenaline early. That is the reason behind it. I think I am clear, sir. Yes.
Priyamda, one question here.
Yes.
How to differentiate perioperative anaphylaxis from intraoperative emergencies? How to differentiate it?
So that is what. So that is it. That is what. This is the card that they have given to us. Suppose a patient has presented with cardiac arrest. Now the person will shout that these are the causes of cardiac arrest. If you can identify, then you know that this is the cause. But anaphylaxis is, you have to have very high suspicious mind that I have given the drug now. And within these few minutes, everything was fine. Suddenly this has occurred because hemorrhage in front of an anesthesiologist cannot happen that fast. That we will always take care. But anaphylaxis is something which is hidden. So most of these causes we know that those are present. But anaphylaxis is the thing that we do not see. So that is how we will, try to think that this might be because of anaphylaxis, may not be because of other problems.
Yeah.
Yes.
So how to differentiate the agent?
Immediately you can. Yeah. Immediately you simply cannot. Anaphylaxis is a clinical diagnosis. If you think it is anaphylaxis based on your clinical diagnosis, it is anaphylaxis. And the diagnostic criteria that has been given is pure clinical. Later on, you send tryptase, histamine, whatever you have got in your facility, and retrospectively now you confirm that, okay, my clinical suspicion was correct. But most of these cases, I have encountered 2 cases of anaphylaxis, proven anaphylaxis in the last 15 years. They respond. They respond to it. One was to a colloid, and the other was to an antibiotic. They respond. So by looking at the response, looking at the surrounding clinical, things, what things were happening, should this hypotension should have occurred in this case? It should not have, right? So all those things will guide you to make the diagnosis of perioperative anaphylaxis.
Thank you so much.
Yes, thank you.
So if a patient has hypotension and the heart, there is bradycardia.
Yes.
And when we auscultate, we see the chest is clear, there is no rash, and suddenly the heart rate goes up to 140.
Yes.
So what should you suspect?
No, because sir,
whether we should think of arrhythmia going into a cardiac arrhythmia causing the hypotension,
sir,
or anaphylaxis. Just at the time of induction.
Sir, I would need a little bit more clinical information. What was the case? What was the anesthetic management when it has occurred, and what was the surgeon doing? Then only we will be able to make a.
So actually, it was a case of submucosal resection.
Submucosal resection.
So started the case pre-medication, then induction with propofol, then given succinate sodium.
Yes.
Then intubated, and just after intubation, atrecolene was given.
Yes.
After intubation, atrecolene was given. Oxygen nitrous, and then
Yes.
dexatomidine was also started.
Okay.
And then suddenly patient went into hypotension. First there was bradycardia of 50, 55.
Okay.
Then suddenly patient's heart rate went to 140, 150.
Yes.
Then fluids rushed. The patient was auscultated, chest was clear, there was no rash. Patient went into hypotension. BP was not recordable.
Yes.
And
So that means the patient was in cardiac arrest.
Yeah.
Sorry about the slide, sir. So please continue. Yes.
So the patient was in cardiac arrest.
Yes.
Then when the fluids were rushed in,
Yes.
patient's BP started coming up, 70, 40, then 50. It started improving. And then at that scenario, should we give an adrenaline? When you are doubting whether it's an arrhythmia, whether if you give adrenaline, whether it's going to aggravate that. So do you, in your opinion, what should be the
Sir, in
IV fluid or ephedramine or epinephrine, whichever, vasodilator, meaning give a inotrope or a vasoconstrictor drug. What is your?
Sir, I am no one to give an opinion.
No, I'm just
right.
in this situation.
But what I can say that what I would have done at that particular time, but I am no one to give an opinion. This should not be regarded as any advice. But in that particular case, we are trained to use some bolus vasoactive substance. Whatever we have got methamphetamine, we have got prepared phenylephrine. The heart rate was very high.
Yeah.
The heart rate was very high. It was around 150 range, right? Or ephedrine, whatever is at my hand, I would use it at that point of time, because nobody keeps probably an adrenaline prepared, right? So I would use it. Looking at the scenario that the patient had got propofol, again dexmedetomidine, and has just been given atrecurium and intubated. So I know that there are lots of other causes that can be because of this hypotension. We clinically know it, right? And so we clinically know how a patient would respond to 1 or 2 doses of ephedrine, or we can predict that. We now by this time we know that this should have been the response. Now if there is that response that we anticipate is not there, let us definitely think about some other sinister things, because we know that this is how the patient should have responded. So this is what I can say, sir.
Actually, this patient I had faced few months back. Then we actually, patient's BP started rising. I was afraid to give adrenaline. That's why I wanted to stress on that.
Yes.
I was afraid to give adrenaline. What sir told, no? I gave ephedramine.
Yes.
I gave ephedramine, BP started picking up. Patient reached 90, 60.
Which sir, how many doses?
I gave two doses.
Two, right? So probably it was not enough, but I am no one to say that.
No,
because that is what the knowledge. Yes.
So I gave this. Then I had no meaning. We didn't start the surgery. We reversed the patient, intubated. We asked the patient, do you have any breathlessness? Do you have any itching? Do you have any chest pain? Patient did not say anything. He was saying, I'm okay, I'm okay. He was always saying that. We put oxygen, we shifted him to ICU. It's a real life situation. I just want to share with the patient survived. That's why. This is a real life what happened. I just want to share my feeling with all the juniors. We shifted him to ICU. ICU again, he started, BP started falling. 70 by 40. Then we rushed in fluid, but we did an emergency echo. And then we saw that the right side of the heart was slightly dilated. And then because we have rushed so many fluid. So that could be the reason. Then the heart was not contracting as
nicely.
There was no regional wall motion abnormality. But the physician said that there is some difference in the regional wall motion. Some difference globally, the heart is not contracting properly.
Nicely.
We shifted it to the cardiologist. There, we did a ABG, we did a blood sample analysis, that is biochemistry, sodium, potassium, all those things we did. And luckily we sent troponin also. Quantitative troponin came very high. So it's a coronary potassium, sodium, everything on, because it's a young patient, 35 years, 40 years, normal patient. only he had one mark from a teacher. That was the only thing which we can obviously see. We had done a pre-op echo. So we were very sure that there was, and when we did, we were surprised that the troponin was high. And we sent the patient to the cardiologist. Actually, there were not much management. They said that it's just cardiomyopathy.
So, if the chairperson just allow me 30 seconds. Sir, troponin in a postoperative period who just had a massive hypotension may not be indicative of coronary event because it simply might just, represent some myocardial injury. So, that also we need to keep it in account. Sir, thank you so much for sharing that incidents. Yes, Dr. Ankur. We are in the same boat, ABC.
Thank you, sir, for the wonderful presentation. I have a small story to say that when I was working in AIMS Delhi, during one particular case, we had to use cell saver. Cell saver is a equipment where we collect the ongoing blood loss from the patient, use that blood in the machine and transfuse the same blood to the patient again. And you won't believe, patient's own blood did anaphylaxis to the patient. So what we have understood that अगर एक पेशेंट का खुद का ब्लड एनाफाइलेक्सिस खुद को कर सकता है, then probably any foreign object to that person may cause anaphylaxis.
Because the blood was returned from cell saver, right?
Yes, yes.
Look at a cell saver.
I agree. Yeah. That is just a statement.
Yeah.
I mean to say, any foreign substance not native to the body can cause anaphylaxis or allergy. It is just the degree or the propensity to cause less and high. And we as anesthesiologists, we should have an eye for that, for that complication. Thank you.
The patient was also done coronary, the CAG, coronary angiography. This is normal.
That was just some myocardial injury because of severe hypotension. That happens many a time.
And the cardiologist said it could be a coronary process first.
Yes, it could.
Thank you.
Thank you. So, sir, thank you so much for giving me this prestigious podium and thank you all for your patience hearing.
We also thank you for accepting our invitation and addressing an important issue here. Thank you.
Thank you.
Thank you, sir, for this thoughtful and very informative talk on perioperative anaphylaxis. And with this, I would like to introduce our final speaker for the day, Dr. Bishwajit Talukdar, sir, an esteemed academician and clinician currently serving as an associate professor at Guwahati Medical College and Hospital. Sir is a dedicated professional who has made notable contributions to the field of anesthesiology, both in academics and organizational leadership. He plays an active role in the professional community as an executive member of the ISA Guwahati City branch, contributing significantly to its academic and scientific activities. I call upon Sir to please come upon the stage and continue with his topic.
Okay. Sorry. Good afternoon, everyone. Thank you for giving me this chance to speak in front of you in this prestigious podium. Thank you, Speaker, Chairman. Actually, I am somewhat native to this place, Maligaon. I grew up here. My father worked in NF Railways, and so it seems like my life has come a full circle, standing here and delivering a lecture on advanced cardiac life support. So before going to starting my topic, all of us here are anesthesiologists, or is there anyone from any other field? Okay, you are from? ENT specialist, okay. And your ortho, general surgery. So this topic, advanced cardiac life support, ACLS, actually before that, I think every one of us here is knows what is basic life support, because these are some algorithms, some set rules which, if followed, can go in a long way in bettering the prognosis of the patients. So for basic life support, which I think everyone should know, we always go for these things, like some steps. So before going to ACLS, we'll say just remind back the BLS. So in case of a cardiac arrest scenario, first we'll discuss the cardiac arrest scenario, which is the mostly discussed topic, and then if we time permits, we will go to the other scenarios also. These algorithms which I have taken are mostly, all of them are from AHA guidelines, American Heart Association guidelines. So for basic life support, we always see, first is the scene safety, then we check if the scene is safe, we check the response of the person. If when we check the response, we always check both verbal response and also tactile. So we will ask the person, are you alright? Are you alright? If there is no response, third we will activate the emergency system. We will call for help, and then we will check in this unconscious person whether we can find the pulse and breathing. Is the person breathing and is there pulse? We will check that for at least 6 seconds and not more than 10 seconds. So we will always check a major pulse, say the carotid pulse mostly, and during checking the pulse, we will also check whether the person is breathing or not. And if we find no pulse, no breathing, we will go for chest compressions and mouth-to-mouth respiration or any other way of respiration, whichever is available with us. That is basic life support. So then comes the advanced cardiac life support. So what is ACLS? It is a step-by-step approach. It is an algorithm which to maintain life-threatening cardiovascular emergencies, building upon the basic life support. It is developed by American Heart Association, but we also have our own some algorithms. Now we are coming up also, we have CCLS, we have NELS, National Emergency Life Support, which combines both trauma and cardiac life supports. So, but today we will be discussing the AHA guidelines only. So, what is added to ACLS over BLS is, it adds advanced airway management, rhythm recognition, defibrillation, pharmacotherapy, and team-based resuscitation. So in BLS, there may be a single or 2 persons who will be giving the life support, but in ACLS it will be a team-based, and it will include these things. It will have airway management. It will have also some drugs that will be involved. So, building upon the BLS. So objectives of ACLS: early recognition and prompt treatment of cardiac arrest. It focuses on identifying the cardiac arrest swiftly, the rhythm and all, initiating immediate medical interventions. Rapid restoration of effective circulation and ventilation, identification and management of life-threatening arrhythmias, prevention of progression to cardiac arrest. Sometimes even in hospital scenarios, if you are prompt enough, we can prevent cardiac arrest by identifying it early. And also it improves the survival rates. It has been seen that if we follow the ACLS guidelines, survival rates increase from 30 to 60% according to some studies. And also people get discharged after having a cardiac arrest. So this is the chain of survival. We have to recognize early, start early high quality cardiopulmonary resuscitation, rapid defibrillation. If it is a shockable rhythm, we have to shock as early as possible. and effective advanced life support. And once if IRSC is achieved, we should have a good post-cardiac arrest care. So what is a high quality CPR? A high quality CPR, there are some points which, and high quality CPR is the basic foundation of both BLS and SCLS. So there are some points which we should always remember. The rate, it should be 100 to 120. The depth, 5 to, earlier it was, they said before 2010 I guess, they said above 100. But now they say it's 100 to 120 compressions per minute. Depth should be 5 to 6 centimeter. Allow total chest recoil after every compression. Minimize interruptions. Each interruption should not be for more than 10 seconds. And maintain compression ventilation ratio in case of adults of 30:2. That is 30 compressions followed by 2 breaths. So that is when the patient is not having any advanced airway, and once there is an advanced airway like a ETT is inside, you have put in an ETT, then it will be 1 breath every 6 seconds. That is 10 breaths per minute. So next important thing in SCLS is identifying the cardiac arrest rhythm. So in BLS we have an AED. If we have an AED, the AED because you don't need to identify yourself. The AED will identify the rhythm for you and tell you whether to shock or not. And SCLS, comprises of a team. In those teams, there will be someone who can who should identify the rhythm as early as possible, whether it is shockable or not. And if it is a shockable rhythm, we should shock as early as possible. So what are the shockable rhythms? Ventricular fibrillation and pulseless ventricular tachycardia, and non-shockable are asystole and pulseless electrical activity. So this is a ventricular tachycardia rhythm, ventricular fibrillation, these are shockable rhythms. This is an asystole, this is a pulseless electrical activity might seem some look like normal also, but when we see the pulse, we will not find any pulse. So what is the algorithm we follow is, we look for scene safety as we discussed, we check for response, check pulse and breathing, we call for help, then we start high quality CPR, then we attach, then like carrying forward into SCLS, we attach monitor and defibrillator, assess rhythm, and as the rhythm is, we follow the algorithm. So if it is a shockable rhythm, or you continue the CPR and monitor will be attached, oxygen will be given to the person, we will shock as early as possible, then we will continue CPR for 2 minutes, we will establish IO access. IO in case of pediatric actually, in adults IO will be a bit tough, but if you don't get IV, we might have to put an IO access, intraosseous access. We will administer epinephrine. Then after 2 minutes, we will check the rhythm again, and depending on the rhythm, we will continue. If it is a shockable, we will give shock. If it is a non-shockable rhythm, we will go to the next algorithm, which is for non-shockable. So after 2 shocks, or after 4 minutes, then we will go for other drugs. Only 2 drugs they have mentioned. One is amiodarone, other one is lignocaine. And during this time, we will also establish the advanced airway. That is an endotracheal tube if possible. If not possible, we will take a supraglottic airway. But that does mean if we cannot establish an advanced airway, maybe sometimes we may not have the difficult airway might be there, or maybe we may not have the technical person who can put in an advanced airway. Then we will continue bag and mask ventilation. And during all this, we will also think about treating the H's and T's. We will come to that. So again, if it is a non-shockable rhythm, again same, we will start, we will continue the CPR of the attached monitor, oxygen. Then we will confirm if it is a non-shockable rhythm, that is if it is a asystole or PEA, we will straight away establish IV access and administer epinephrine. Then we will continue CPR for 2 minutes, we will check rhythm again, and then follow whether it is a shockable or non-shockable. If shockable, we will go back to the first algorithm, that is for shockable rhythm. And if it is still non-shockable, we will continue CPR. Now the drugs, epinephrine that we administer should be repeated every 3 to 5 minutes. And again, here we will always identify the H's and T's. So what are H's and T's? So H's and T's are the reversible causes of cardiac arrest. There are 5 H's and 5 T's: hypovolemia, hypoxia, hydrogen ion, that is acidosis, hypo or hyperkalemia, and hypothermia. Then 5 T's are tension pneumothorax, cardiac tamponade, that is cardiac tamponade, toxins, thrombosis, might be pulmonary, might be coronary. So these are the reversible causes which we will try to identify by using whatever we have, these things. Say for hypovolemia, we can see the BP. If possible, we can put an arterial line also. Then for hypoxia, again we will have the monitors. We will know. And also we will treat it as and what is which necessary. So acidosis we can check by getting an ABG. Hypo or hyperkalemia also we can get from the blood studies. Temperature we can tell us if there is hypothermia. So amiodarone dose will be dose of amiodarone. If it is a shockable rhythm and after giving 2 shocks rhythm is not reverted, we can go for amiodarone. That is first dose of 300 milligram bolus, and it can be followed by a second dose of half the dose, that is 150 milligram, at least after 10 minutes. Again, also we can also use lidocaine, that is lignocaine, 1 to 1.5 milligram per kg, followed by a second dose, which is half the dose again, 0.5 to 0.75 milligram per kg. So we should always maintain a CPR quality, and once we put in a ETT, and if you have capnography, our target should be always ETCO2 more than 10 millimeter per of mercury. So if it is 10 or more, that means our CPR quality is good. Again, also we should rotate the compressors every 2 minutes. So while giving shock, we should always remember shock in cardiac arrest. Shock should be 120 to 200 joules. If it depends on actually in the defibrillator it is mentioned the shock that should be given in cardiac arrest. But if it is not mentioned, we give the highest shock possible with that defibrillator. So in biphasic we give 120 to 200, and if it is monophasic we give up to directly 360 joules. So second and subsequent doses should be equivalent or higher dose may be considered. So how will we know if there is return of spontaneous circulation? So after every 2 minutes, we will check the rhythm. While checking the rhythm, if we find some normal like rhythm coming on, then we will check the pulse. If there is pulse, for at least 6 seconds again, if there is pulse and rhythm is also somewhat normal, and also there will be jump in the blood pressure also if there is an arterial line put in. Even with NIPP also will see some blood pressure. And if there is an ETCO2, there will be a jump of ETCO2 which was around 10. If you are giving a good CPR, it will come to near normal, that is 30 to 40, range of 30 to 40. So if we find any of these, then we will say that there is return of spontaneous circulation. So once there is return of spontaneous circulation, we will then follow to the next phase, that is post-cardiac arrest care. So how we treat that, we already discussed. If there is hypoxia, we give oxygen. Hypovolemia, we give IV fluids, all those things. We treat underlying causes. So also ACLS, the AHA has told us when to stop termination, stop the resuscitation. Is there any point in going on with CPR? So we have to ask these questions. If arrest is not witnessed, no bystander CPR was given, no return of spontaneous circulation before transport, no shock was delivered before transport. If all criteria are present, then they say we can terminate resuscitation. But if any of the criteria are missing, that means if arrest was witnessed, these are all negative points. If there was bystander CPR, if there was return of spontaneous circulation, or if there was shock delivered before transport, we will try and continue our resuscitation. So I think this is what we discussed. Or this is what we. Is it clear? Okay. Is it clear to you? Let me try if I can. Okay, this is the algorithm of the post cardiac arrest care. So once ROSC is obtained, we will continue our respiratory or ventilatory efforts to manage our respiratory parameters. We'll continue 10 breaths per minute that we have done after getting an ET tube in or advanced airway in. We will try to maintain a SpO2 of 92 to 98%, PaCO2 range of 35 to 45 millimeter mercury. Our target systolic blood pressure will be around 90 millimeter mercury and mean arterial pressure of more than 65 millimeter mercury. So they have said if required we can use vasopressors or inotropes to maintain this. Then we will obtain a 12-lead ECG. We will consider for emergency cardiac intervention like PCI. If there is a unstable cardio, we will check for any MI present or any mechanical circulatory support required. Then we will also check the patient neurological sensory of the patient, whether the patient is following commands or not. If the patient is following commands, the patient is awake, we will continue the critical care management. If the patient is not following command or he is comatose, then we go for targeted temperature management. For targeted temperature management, we will decrease the temperature. We will make a patient hypothermic. We will try to we will try to keep the temperature to 32 to 36 degrees centigrade for at least 24 hours before bringing up the temperature again and checking the the sensorium of the patient. So once stabilized, we will do this cardiac evaluation, hemodynamic support, neurological care, 30 to 36 degrees for at least 24 hours. After, we will also be monitoring the EEG. We will perform brain imaging and do a neurological prognostication. If the patient is still comatose after 72 hours, this patient may, again, if there is, we think the neurological outcome will be poor, the patient becomes a candidate for organ harvestation also. And if the patient is awake, we continue all our critical care management as and when which are necessary. So that is for cardiac arrest and post cardiac arrest care. Now next, SCLS guidelines for bradycardia. So if there is a bradycardia and heart rate less than 50, we will assess for the appropriate clinical conditions. Whether we will get a 12-lead ECG and we try to identify the rhythm. There can be many causes of bradycardia. We try to identify and treat it. We also, in the meantime, we ensure patent airway, assist in breathing as necessary, oxygen if the patient is hypoxemic, cardiac monitor to identify rhythm, monitor blood pressure and oximetry, IV access, 12-lead ECG if available. We don't delay therapy. Consider hypoxic and toxicological causes for bradycardia. If the patient is hemodynamically unstable, persistent bradyarrhythmia causing acutely altered mental status, hypotension, signs of shock, ischemic chest discomfort, or acute heart failure, we go for atropine. If atropine is ineffective, we can go for transcutaneous pacing and or dopamine or epinephrine infusion. If these signs are not present, this acute altered mental status, hypotension, signs of shock, all these signs are not present, then we just continue reassessment. And also we should consider always expert consultation and transvenous pacing if the condition requires so. Dosing, atropine dose, first dose is 1 mg bolus, repeat every 3 to 5 minutes, maximum 3 mg. Dopamine IV infusion rate should be 5 to 20 microgram per kg per minute, titrate to patient's response, taper slowly. Epinephrine IV dose 2 to 10 microgram per minute, infusion, titrate to patient response. Also consider other possible causes like drugs, some toxins, beta blockers, hypoxia, and electrolyte imbalances. Next, SCLS algorithm for managing tachycardia with a pulse. Tachycardia without pulse, we have already said, for tachycardia with a pulse, with heart rates more than 150 per minute, we will assess appropriateness for clinical condition. The heart rate should be typically more than 150 per minute. We assess for and treat the underlying cause again. We always ensure that ABC, patient airway is patent or not, breathing assistance if required, oxygen if the patient is hypoxemic, monitor should be attached, trying to identify the rhythm, then also monitor blood pressure and oximetry. IV access should be taken and 12-lead ECG should be done. Again, if there is persistent tachyarrhythmia, if the patient is hemodynamically unstable, we go for synchronized cardioversion. And if the patient is hemodynamically stable, then we see the QRS complex. So when we say that a patient is hemodynamically unstable, if there is altered mental status, hypotension, signs of shock, ischemic chest discomfort, or acute heart failure, then in these cases we go for synchronized cardioversion. During cardioversion, we consider we always go for sedation if possible, and if regular neurocomplexes we should consider adenosine also. So now QRS, if QRS is wide or not. If QRS complex is more than 3 small squares, that is 0.12 second, then we go for, if it is more, that is we call it wide QRS, and if it is 0.12 or less, we call, say it is narrow complex tachycardia, narrow QRS. So wide QRS, we will again obtain IV access and consider adenosine only regular and monomorphic, consider antiarrhythmic infusion and expert consultation. For narrow, we will again take IV access, attempt vagal maneuvers, adenosine if regular, beta blocker or calcium channel blockers, and again consider expert consultation. Always expert consultation should be taken. Even if after giving all those, the patient is having refractory tachyarrhythmias, we should always treat for the underlying causes. Need to increase energy of cardioversion, addition of antiarrhythmic medications, seek expert consultation. So synchronized cardioversion should be device specific and recommended energy level to maximize first shock success. Adenosine dose, they have said 6 mg rapid IV push, followed with an NS flush, second dose 12 mg if required. Antiarrhythmic infusions for stable wide QRS tachycardia, we can use procainamide, IV dose or amiodarone IV dose. Procainamide is 20 to 50 mg per minute until arrhythmia is suppressed, hypotension ensues or QRS duration increases more than 50%. Or maximum dose 17 mg per kg is achieved. Maintenance infusion 1 to 4 mg per minute. Avoid if prolonged QT or if there is congestive heart failure. IV amiodarone dose, first dose is 150 over 10 minutes. Repeat as needed if VT recurs. Followed by maintenance infusion of 1 mg per minute for first 6 hours. We can also go for beta blockers. Sotalol, they have advised 100 mg, 1.5 mg per kg over 5 minutes. If QT is prolonged, then we should avoid. So, lastly, we come to the SCLS team dynamics. As we had earlier discussed, SCLS is a team effort. So, there should be always there is a code leader who directs the team and makes critical decisions. That person assigns the roles of who will be doing what. Someone has to be doing the taking care of the IV drugs. Someone is taking care of the airway. Someone has to keep a log of whatever is done. Someone will be continuing the chest compressions, and if required, there should be a person who will change the compressor every 2 minutes. Always there should be a closed loop communication among the team members. Whatever the team leader says, once someone has done it, the person should repeat back and repeat back to the team leader that this thing is done. Whatever the direction was given was done. That's how we close a communication loop. Always also keep a monitor the CPR quality. All those high quality CPR points, we should always monitor them and reassess regularly, re-evaluate the patient's condition, that is every 2 minutes. The commonly used medications we have already discussed. Conclusion, importance of SCLS is it adherence to evidence-based algorithms which give us better results, skilled teamwork and communication, with efficient collaboration and clear communication among team members. Timely defibrillation is always important, and drug administration as advised by the guidelines. Continuous reassessment and management. The patient should always be ongoing. Continuous assessment should be always ongoing. Every 2 minutes, we should assess the condition of the patient. Thank you.
Thank you, Dr. Biswajit, for the lucid presentation. Before taking question from the audience, I would like to ask just one question. in high quality CPR, it was mentioned that we should allow the chest to recoil back fully. Yeah. Why should we allow the chest to recoil back fully? Yeah. Give me two reasons, or three maybe.
Yes, actually, if we don't allow the chest to recoil properly, after every subsequent compression, the heart will not be filled, and the blood will not reach enough blood will not reach brain, which is our target to send the blood oxygenated blood to brain.
And what about the coronary circulation? When does it take place?
It takes place during the diastole.
Yeah, diastole. That's why we need to. We need to allow the chest to recoil fully, because during that period only, chest coronary circulation take place. Because if you keep on compressing, the chest won't get enough blood itself while you are trying to supply to systemic circulation. That is also another reason. Yeah, exactly. You should allow so that the heart get filled, so that we can go for the next chest compression.
Thank you.
And the other one is coronary circulation during diastole. That is also an important point. We can take some questions from the audience. I hope there is no more questions, right, sir?
Thank you.
Thank you.
Thank you, sir, for your detailed talk on ACLS. And with this, we come to the end of our scientific program. Now, I would like to call upon stage our distinguished speakers for this session, Dr. Ankur Khandelwal, sir, Dr. Priyam Saikia, sir, and Dr. Vishwajit Talukdar, sir, for the felicitation ceremony. And I request our distinguished chairpersons, Dr. Maheshwari, sir, and Dr. Emmanuel, sir, to felicitate our speakers. And I also request to come upon stage our respected MD, sir, Dr. B.P. Deka, sir, that for felicitation of our respected chairpersons. Thank you. So we come to the end of our RAISACON conference. I take this opportunity to thank all the speakers, the officers, the participants and the delegates for your patience listening and cooperation. I now call upon stage Dr. Piyush Sarkar sir for the valedictory speech.
Now, as we come to the closing part of this two-day event, as ceremony is a valedictory part to thanks and get feedback from you. So I would request our organizing chairperson, Dr. Bibeleka sir, to take chair. I will request Dr. Mahasi sir to come on sir for the valedictory of film fund. And Dr. Ravi to be on stage. Whom I can see here, my scientific, oh, Dr. Sazal, yes. Before, as organizing secretary, before I thank everyone, I would like to have some feedback from the delegates who are present here, who have come from outside. What we are lacking of, how to improve it, if you have you find anything good about it, please give some comment to us. Any feedback?
Outside, just big thanks to you all. It was truly a pleasure to attend such a successful and engaging anesthesiology conference. The event provided an excellent platform for learning, professional interaction, and meaningful collaboration. The overall arrangements were outstanding. The stay was excellent. The food was exceptional, and travel arrangements were very comfortable. The temple visit was also smoothly organized, allowing efficient use of time and adding a memorable dimension to the experience. My sincere appreciation to the expert faculty for sharing their valuable insights, innovative ideas, and vast clinical experience. The conference created wonderful opportunities to connect with the fellow anesthesiologists, exchange perspective, and strengthen professional networks aimed at advancing patient care and safety. Kudos to the organizing team for conducting a well-structured program with thoughtfully curated session and seamless coordination throughout the event. Looking forward to many more such academically enriching gatherings. Thank you very much. You all have done a wonderful job. Sir, it's really a milestone in the history of the Railway Association of ISA conference, and it is really different from the other conferences. Thank you very much.
Thank you, sir, for your encouraging words. It really meant a lot to us. I would like to listen from the juniors at least. Anyone? Yeah.
Good afternoon, sirs and ma'ams. I'm Dr. Nishan from Southern Railway, DMO. it was a very good conference, especially the second day anesthesia conference was very good. I'm an anesthesiologist. The topics were good. Just a small suggestion that since it is the second day, the timing of the conference could have been a little bit shortened so that it would have finished by maybe 3 o'clock. I know there are constraints regarding that conference registration and maybe CME hours mandatory. But that second day, since we are at the second day, the number of delegates present at the last are very less. So that could have been done. Otherwise, it was a very nice experience. And maybe from next time, a separate consolation prizes to be given to those delegates who are till last, so that there will be encouragement for them to be till the last. There should be some kind of a felicitation for them also.
Point well taken. We'll keep this in mind.
Thank you, sir.
Anyone else? Yeah. Gita ma'am is our ex-member, so no, you are from the hospital, but still, yeah. To the left.
Thank you and good evening to everyone. Especially this was a very nice conference. Within 2 days, many topics has been covered. Though it is organized by the RAISA, but the other topics of the other departments, other specialties has been covered. So it is a very good experience for us also. And accommodation was very good. Food and lodging is also very good. So thank you.
Sir, regarding the conference, the 2 days, like myself, I'm Dr. Kannan, ADMO, Jabalpur, WCR Central Hospital, and it was very well organized when we take both the academic, if you see the academic part from anesthesia point of view, and also the topics which were included on the first day. Those are really informative. It was very nice. And on the other hand, the other arrangements, for example, the food, the cultures, the accommodation, everything, including the darshan, everything was perfect. So I should say it's been a great thing. Okay, feather in the hat of NFR. Okay, thank you.
Thank you very much.
Good evening, sir. Myself, Dr. Aditya. I am ADMO, CKP, Southeastern Railway. And I am highly thankful to this zone for organizing this event. And it was a nice event where I met so many anesthesiologists of our zone and beyond that. And it was a good platform to learn many aspects which I don't know and which will help me in future for performing my clinical and administrative works. Thank you so much, sir, for organizing.
Thank you very much for your kind words.
Good afternoon, seniors. Myself, Dr. Priyanka. I am ADMO from Bhopal, WCR. First of all, thank you so much for giving us an opportunity to attend this conference and also to visit this beautiful state and to experience the culture here. Everything was perfectly organized, including the topics, the food, the other arrangements, and also the cultural evening yesterday. Thank you all again. Thank you so much.
Thank you.
Good afternoon, everyone. Dr. Milenia, ADMO Central Hospital, Bhubaneswar, East Coast Railway. It was a very well organized conference. From everything from accommodation, food, transport, everything was very perfectly organized. And the topic chosen for the conference was also really good. I'm like just post MBBS. I'm not done my specialty PG course. So it was like general topics were also useful for me, and anesthesia topics, the basic ones also were covered. It was helpful for me. And only suggestion was regarding the time. Time constraints were there, sir.
Yeah, we understand that.
Only that suggestion is there, sir. Rest all were very well arranged, sir.
Thank you, sir.
So you spoke very well, है ना? You should speak. Dr. Gita.
See, I don't have to introduce myself to the people of NFR, but maybe for the juniors over here, I'm Dr. Geeta, ACMS East Coast Railway, and I pursued my DNB in this hospital. I've just passed out a year ago. So for me, it was coming back home. And for the organizers, it was a really beautiful 2 days, an academic fest, in fact. And for me, it was brushing up so many things which I've learned just a year ago. And as said, the only thing was time constraint and maybe a few glitches yesterday, so which increased this problem. But overall, it was really fantastic. Thank you very much.
Anybody else from audience? So I will speak sir few words.
Yes, sir.
I am Dr. Chandrakant Patel, ACMS, Raipur Division, ICCR sir. So I have visited Guwahati 2-3 times before also. And in a railway conference of anesthesiologists, I think this is my first time. But the arrangements, right from the receiving, accommodation, venue, I appreciate this beautiful venue of the conference. We don't get such a good conference hall anywhere, at least many places wherever I have gone. This is the best venue I could see with the proper illumination, adequate space for the audience and the podium also, the stage also, and connecting just the dining area or that lunch area is also very properly designed and the organized also in a similar manner. And the organizers like our Dr. Maheshwari sir, Dr. Saha sir, respected PCMD, MD sir, they all have put their collective effort to bring this grand success to this conference. So I congratulate all our organizers, sir, seniors, and the team of the doctors from the NFR Central Hospital used. When you are communicating with them in WhatsApp, you don't feel like they are relatively junior doctors like Ravi Kiran also. Their response in the WhatsApp was in very professional, in very polite and very competitive manner, which we don't see most of the time in other railway conferences. You go on asking something and you will not reach anywhere. But here the scene was different. And from the headquarters also, I know the Dr. Jana personally because of my previous connections. His involvement was also very much in this conference, though he is not here. So overall, all the NFR team, medical team, is the credit goes to the team NFR for this successful conference. Thank you very much. Thank you.
Thank you. Thanks a lot. I would like to request our organizing chairperson, Dr. B.P. Dekar sir, to say a few words.
Thank you for the good words. Actually, I have taken some points from you. Actually, the idea of the conference was given to us only in the month of December. I think CMD meeting was there and where the DG wanted to have a conference at and even though it subsequently, Dr. Maheshwari and Dr. Shah came to me and said that they want to have this RAISACON. So that's why we clubbed it. That's why that there was a constraint in the time constraint and multiple topics were arranged. So we did one day for the multiple speciality and the second day we arranged for the RAISACON. That's why we could not finish before lunch. Usually what happens that conference is from morning to next day only up to lunch. But as RAISACON also has a lot of topics, so we have to have a longer scientific session for the benefit of you all young anesthetists. So that is the one reason for that. Then once we have decided, I am lucky to have this young team who has worked very tirelessly to see this day. And I'm also very grateful to our general manager, sir, because when me and Pijus and CMD madam went to general manager, it is a protocol to have a permission from them. And he immediately said that we will have our guest at Radisson Blu. So it's a never thought about idea. And then we were worried about how to get the fund. It's very difficult to get a fund from for allowing the guest to stay outside. He said that we will arrange it, you process the file, and he gave one earlier occasion, one conference was there with the construction people. So he said that you take the guidelines from them and I am there, so you will do it. That's how we could arrange the stay. Initially we wanted to have more rooms, but because of IPL, you know, IPL is going on, so I think tomorrow there is a match at Guwahati. So they booked some hotels. So otherwise we could have, means, you know, every doctor should have been there only. But then, okay, we could give at least to some doctors. So we have a very good support where accounts people or the general administration supports us. And we could get the vehicles to us. And we have a very good administrative support also. And we did everything nicely. And even though you have said a lot of things about the hall, I got two suggestion from my fellow CMDs. They said that after visiting my hospital, they said that you could have arranged the seminar there. Sir, I will request you to visit my hospital and see the seminar hall there also. So madam told me that Western Railway, Southern Railway, Central Railway madam and Nirmala madam went there and they saw the hospital and they commented that you could have had the meeting there only, and because that hall is also a very good hall. And regarding topics, yes, when I saw the scientific this one, I thought that there will be an issue because every speaker cannot stick to this time, and sometimes it is not possible also to express everything within the time limit. So it happens, and we will take care of that maybe in the next conference if we had. I am very glad to say that the young anesthetists, they are still here. Usually in the valedictory function, there are very less people. So I congratulate them, and it's very nice to see that the young anesthetists of railways are taking interest in academics. It's a very nice sign for the railways, and I congratulate them for that. And I also congratulate my whole team. They have worked hard, and that our anesthetists, DNB students, from morning to evening, they are working there. So I congratulate Sanchita. Please come. Come on. Come. So these are the young people who have supported us. Sankalpa. Then my ANO was quite gracious to allow the nursing staff to be here. They have worked hard from morning to evening. Then I request all my team who have worked hard, please, Ruby, Arushika and all, Emmanuel, please, Manisha, please come back. And my special mention to Dr. Bidyut Gogoi, who is the editor of the Souvenir, who has left his important work of radiology and was sitting there in your press to do all the things. He has nicely done it. I also, she's not there. Dr. Anamika, she arranged all the finance actually. To get the finance is very important from the panel hospitals. They have come forward. No, no. One more person I would like to name because Sir has mentioned about the prompt replies. You must have seen in that list Broja Kalita. And he is there at the control room still now, I think. And he is managing everything. So I think that I should appreciate his work also. Thank you everybody. And last, let me just say something. So, as we come to close the first RAISACON and NFA Zone Medical Conference, as I has already said, it was originally planned to be a multidisciplinary conference. So we were proceeding for that one, but then fate has something else to do. It was supposed to be you all, turned out to be right. For the organizing secretary to deliver the thanks. I won't take much time of it, but I have mentioned few names before I conclude, because you may be seeing me, you may be listening from me and seeing that I'm managing the things, but no, I'm only the face. The whole body, the whole work was done behind me. So I have to mention, I have to give the due credits where it is due. As Sarah said, I would like to thank GM NFA. He was gracious enough and encouraged. His words were so encouraging that I was sure that whatever we are planning, we can pull it off. The first day we met him, he only said, "What's your plan?" I said, "We want to have this one thing, and that delegates from all over India will arrive here." So sir said, "What do you want from me?" I said, "The assistance, because if you say something, then all departments will accommodate, so it won't be an issue." So I said, "Let's do one thing. Let's accommodate the delegates in a hotel." Sir, hotel, let's accommodate Radisson Blue is nearby, let's accommodate the Radisson Blue. I was shocked. Because to think of to accommodate all the delegates in a 5-star is beyond imagination. Those who have arranged a conference in railway, they will know how difficult it is to get the funds, to get the thing. But he said that. I said, okay, maybe he is saying like that, but it won't be possible in that way. For the first day meeting happened, we planned the thing. I again went there to meet him. And sir said, I asked him, "Sir, okay, we are planning, but only thing is that, sir, how will I get the fund?" Sir, what was the fund is my headache. You plan it and place it words. Fund is my headache. I will move whatever I have to move, and you will get the fund. Don't worry. And we were planning in that way. It was originally planned for 13th and 14th. We were going smoothly. But then suddenly on 13th and 14th, PM visit was planned in here. And railway was involved in the last moment with some inaugurations all. GM sir was invited there. So we have to postpone at the last moment. And then it was scheduled from 27th to 28th. And as we were in touch with Radisson Blue to get the rooms and all the negotiations was being done, suddenly dates of IPL was announced, and an IPL match was to be happened in Guwahati on next day tomorrow. So the IPL, both the teams, the moment the date was announced, the whole hotel was booked. No seats available.
But because we were negotiating it all, they said, okay, let's give our plan when you are coming, when you are leaving, how many rooms we can provide you, let's see. Then they said, okay, we can provide you at best 20 rooms, not more than that. There's no way we can provide you more than that because from 28, not possible to give you even a single extra room. If you want to put the delegates there, we can give you on 26th as many rooms you want, but not beyond that. But getting rooms on 26th alone meant nothing for us because most of the delegates will leave on 29th and 30th. So whatever rooms we could get there, we arranged that thing. And still, I think it was not very uncomfortable for you to have the accommodations, whatever we provide to you. So, a very big thanks to GM sir. Next, definitely my PCMD ma'am. She is the person who never said no. Whatever I proposed, whatever we said, she only asked, can you do it? If you can do it, go ahead. I have no objection. Just tell me what I have to do, where I have to sign, whom I have to call. We'll do it. That's how it's running. And definitely, MD sir, for believing in me and guiding me throughout these events. As I said, I'm not an anesthetist to have that RAISACON here, but sir believed in me that I can do it, and sir entrusted me. Thank you, sir, for believing in that and being the guiding force. Dr. Mahasi sir is here. Only one thing. Sir is a true leader. Whenever we were in travel, whatever suggestions we need, I just have to be there. And sir was always ready to help. So, thank you, sir, for being so kind enough to guide us. MD sir has mentioned Dr. Namika Fukan. She is not here, but I would have definitely like to give personal thank you note to her. Because GM sir has said you will get the fund here and there thing, but to move the file, to contact every time, to have the enormous calls to the accounts department to get the files cleared, get the file vetted. She was constantly nagging to that, and her effort made this, practically made this event happen because of the funds she could provide us. And another person of the dais, please give a big round of applause for Dr. Dev Mr. Sir. Sir, please stand up, sir. I want everyone to have a look at you, sir. Everyone was praising me that I arranged their Kamakya Darshan. Sorry, it was not me, it was he. As I said, I'm the face. I'm only the face. I did nothing else. In the election time, the district administration is completely busy with election matters. They are not touching anything else. Every other unimportant matters, they are keeping files there. When we asked for the permission for the delegates to have the Kamakya Darshan, they simply denied. Sorry, we don't have time for this. But this was the effort of the Mr. Sir that you could get the pass. It was effort. He went personally to the ADC room. He sat there whole day to get the ticket to passes signed there. It was effort of him that we could arrange the thing and you have the darshans today. And the scientific sessions you were talking about, it enriched. Yeah, it was a bit lengthy, we understand. It was a bit lengthy because there were some constraints from us. We have to accommodate our sponsors. We have to look for the credit points, hours, the things. But the structure, the man behind me, Dr. Somnath Saha, And he not only managed the thing, arranged the thing, the scientific session, how it will look like, he took personal effort for the arrangements of accommodations also. Who will stay and when they are coming, when they are going. So thank you, sir, for helping me on this note. I would like to also thank Bidut Gogoi sir. Where is he? He was there right now. Anyway, I must say sorry to him also, because I have a habit of keeping the things pending. Okay, we will be done at the last hour. We will be done at the last hour. I provided him all the data. I provided him all the materials to be published at the very last moment, and still he pulled it off. He could manage to publish the souvenir at the right time. So thank you, Dada, for helping me. Thanks to Dr. Ruby. Dr. Dulab Dule is not here, for the wonderful cultural event that they arranged yesterday. Yes, we were late, so we could not enjoy the whole program yesterday, but they managed it beautifully. And thanks to all the DNB students, Dr. Sanchita, Dr. Aman, Dr. Gopi, Dr. Emmanuel, for managing the scientific session so well. And another person, I want all you to applaud the effort of Dr. Ravi Kiran, please. I was talking to everyone, but the things that was needed in paper, he was the man. I just call him, Ravi, do this. Ravi, send this letter. Ravi, send this email. Ravi, call this person. And it was done immediately. I don't have to think again. Don't have to look back whether it was done or not. I know I have told him and it will be done on time. So he is the man I could relax actually. I initially started to write down but the way he was managing everything electronically. Everything was on Google Sheet. So everything was available to me on the click of a button. I could see what was done, what is going on, what is not. So thank you, Ravi, for being there. A special thanks to all the sponsors, to all the hospital staffs, to all these beautiful ladies. Hello, ladies. Oh, they're busy here. Anyway. Special thanks to all these beautiful ladies for managing the reception, for managing all the felicitation programs so smoothly. Thank you all. And lastly, a thank you to all the staffs of electrical department, the S&T department. I just called them that I want you to be at this time and throughout the day. They said, sir, okay, we are ready to do whatever you are saying. Just inform this to our boss and we will be there. And they are here. Initially, when I issued the letter to the Deputy CST for all this, it was for till 5 p.m. But today, someone asked that because we have anyway, those who were saying that what to be there for the late stayers who are staying till now, we have the dinner, okay? Don't worry. Anyway, jokes apart, someone asking that because at the evening there is nothing else to do, what will you do here? So I asked what you would want to serve. So I said, can you arrange some singing thing, like we would like to sing and all, ourselves know all. So I asked them, can you be there till 10? We want to have fun. So they agreed. Though their duty was till 5, now they agreed they will be here till 10. So all you there who wants to sing, who wants to dance, please be here. During the dinner, we'll do that. Sorry. Calls for my vendors. So, as I conclude, I sincerely hope that this event was really fruitful. The effort we made was fruitful. It helped you scientifically. It helped you also to enjoy this beautiful city of Guwahati. Thanks a lot for being here. Thank you. Okay. Heidi is being served there outside. Please enjoy it. Please.
Requesting everyone to be on stage. Shall we take a group photo, please?